Good morning, Dr. Epen. How are you?
Good. Thank you, Chair Foster. Ready whenever you guys are.
Okay, yeah, you have everyone on your side?
I think so.
Okay, so before we go on the record, I'll call the meeting to order. I'll have Mark swear in the witnesses, and we'll just do the health network witnesses first. And then when we come back to UVM-MC, actually, I'm sorry, let me ask you this, Dr. Epen. Are any of the UVM-MC folks or CVMC folks or Porter folks speaking during the HN presentation?
During the first 30 minutes?
Yeah.
No.
Okay.
But I think I asked everyone to be present, so you could do it however you want, but we're ready you could swear us all in the morning if you want. We'll be around all day, or however you want to do it.
All right, let's do that. That's probably easiest. So I'll have Mark swear literally every single witness in, and then we'll turn it over to you, Dr. Epen. You can do the UVM HN presentation.
Thank
Okay,
you.
So Mr. Miller, we can go on the record.
Ready to go.
All right. Good morning. Today is August 11th. We have the UVM Health Network and Health Network Hospital presentations today. I'll turn it to Mark Hengsler, our counsel, to swear in the witnesses, and then Dr. Epen and his team to provide a presentation relating to the health network.
Good morning, everybody. So what I'm going to do is administer the oath for all witnesses testifying on behalf of UVM Health Network and then the 3 member hospitals that are going to be speaking today. For the purpose of the record, what I'm going to do is read the oath and then ask each person who intends to testify to unmute themselves, state your name for the record, and then affirm the oath. And if we can just go through person by person, that way we have the record complete in that respect. Okay, so do you solemnly affirm that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth under the pains and penalties of perjury?
Sonny Epen, I do.
Rick Vincent, I do.
Ramsey Harrington, I do.
Steve Leffler, I do.
Judy Peakley, I do. Anna Noonan, I do.
Kim Patnode, I do.
Bob Wertmeyer, I do.
Scott Como, I do.
Kelly Champney, I do.
Brad Crumpf, I do.
Mark Stanislaus, I do.
That sounded like everybody. So with all witnesses sworn in, I'll turn it over to the network for its initial presentation.
Thanks, Mark. Sonny Epen here. I'll start us off. Chair Foster, members of the Green Mountain Care Board, we really appreciate the opportunity today to participate in the review of the University of Vermont Health System's Vermont hospital budgets for the fiscal year 2026. As you consider the budgets of the University of Vermont Medical Center, Central Vermont Medical Center, and Porter Hospital, we recognize you'll also be looking at how they align with the broader financial operations of the UVM Health Network. These budgets not only reflect the unique needs of each hospital, but also try to demonstrate the collective work we're doing across the system to advance Vermont's healthcare policy goals. To that end, following my opening remarks, Rick Vincent will speak about our financial outlook and offer a look into the ways we've worked to make the health system's shared administrative services more efficient. This has been a very important focus for us as it has enabled us to achieve some of the rate decreases reflected in the hospital budgets before you without reducing clinical services. Following Rick's remarks, I've also asked Dr. Ramsey Harrington, our Chief Physician Executive, to spend just a few minutes talking about how our FY26 hospital budgets benefit from our system medical group. This collaboration allows improvements and efficiencies in clinical care across UVM Health Network that directly benefit patients. Our proposed budgets before you align with the board's FY26 guidance and reflect the impact of recent orders and newly enacted state laws. They represent our work to make high-quality care more affordable and more accessible. Overall, our FY26 commercial rate requests are as follows. UVM Medical Center is proposing a 7.9% rate reduction. Central Vermont Medical Center is proposing a 3.6% rate reduction, and Porter Hospital is proposing a 3% rate increase. As we submit these budgets, we're working together to reduce administrative spending, reduce commercial insurance charges, and make our administrative and clinical services more efficient. These are essential steps to improve how we better serve our patients, strengthen the quality of the care we provide, and operate as a sustainable and stable organization. This is a volatile and deeply challenging time for healthcare, both across the country and in Vermont. As we take on the crucial work of addressing affordability, looming cuts to federal Medicaid funding threaten to make an already fragile situation even more difficult. As a nonprofit academic health system, we will not turn patients away based on their inability to pay. But these cuts will further strain an already stressed system. Despite this delicate balance, I want to be really clear. My colleagues and I share the same sense of urgency felt by our community when it comes to reducing healthcare costs. We are committed in doing our part right now and in the future to lower healthcare expenses and ensure high-quality healthcare remains available to all Vermonters. I want to thank our community, you, the Green Mountain Care Board, our volunteer boards, and the many hospital and home health staff that continually work together in this constantly changing healthcare landscape to deliver high-quality, equitable care to our patients and residents. So our FY26 budgets submitted by our Vermont hospitals reflect three core priorities. Number one, continue to deliver high-quality patient care. Number two, accelerate our efforts to address the rising cost of healthcare. And number three, protect patient access to care, particularly through our expanded outpatient services and telehealth. I'd like to take a few minutes to walk through each of these priorities because they are what are driving the work across our system and are reflected in the budgets at each of our hospitals as submitted. So delivering safe, high-quality care to all patients is at the foundation of what we and all hospitals do. By unifying our health system, our goal is to provide the best possible experience for each patient by aspiring to outstanding outcomes and high standards across locations that demonstrate consistency in the quality of our care. This is what our patients expect and what they deserve. To that end, this year, we've made changes to strengthen our approach to quality and safety. With great respect for quality measures like the CMS star ratings, we're pinpointing key spots in our healthcare system to improve, which is something the board had inquired about last year. We know this is an important tool for patients when researching their healthcare options. Through a strengthened and improved shared services quality function, we're also improving the way all of our healthcare providers work together while maintaining and respecting the unique strengths and needs in each of our locations. This includes improved internal accountability measures to support our progress. We will continue to explore what's working, where we can standardize processes and procedures for the best outcomes, and offer care that's informed by research and evidence-based practice. As I mentioned earlier, we share the sense of urgency to address affordability, and the budgets before you reflect an important step in our commitment to reduce the cost burden on Vermonters. The budgets before you today are in compliance with the board's FY26 guidance and include reduced commercial rate requests for UVM Medical Center and Central Vermont Medical Center when compared to last year. These rate reductions reflect the board's 3% commercial rate guidance, adjusted for the FY23 enforcement actions on net patient revenue, and the impact of recent state legislation on prescription drug pricing. As a part of this work, we recently made, as you know, the challenging decision to eliminate 146 administrative and non-clinical leadership and staff roles across our system. Of those, 77 of the positions were filled roles, which of course resulted in their layoffs. These positions represent valued team members who've made significant contributions to our organization. In our closely connected community, these decisions inevitably impact friends, neighbors, and family members. We've also stopped recruiting for hundreds of open roles that are almost entirely administrative in focus, and we've done this throughout this year. In addition to these reductions, we've undertaken a number of other measures also to reduce expenses. We've scaled back our capital budget, focusing only on projects with the greatest need and long-term impact. We're pursuing greater clinical efficiencies, including reducing unnecessary testing, shortening stays, and delivering more localized care and making strategic decisions about the medical devices we use. We've cut spending on travelers and locums by creating a shared pool for temporary staffing and working on boosting retention among our nurses and physicians. We're downsizing or consolidating our underused physical spaces. And following discussions with our senior management, our system board of trustees has eliminated at-risk variable pay for all leaders this year. The third FY26 priority is protecting access to care for our patients. Through a focused and centralized effort on retention and recruitment, we're bringing more providers into our health system to address critical patient needs. For the first time in many years, we're having more success in this area, and we're increasing the number of permanent providers delivering care in Vermont. Another key tool in access to care is how patients schedule appointments. Soon, patients will be able to not only schedule their own appointments, but be provided with information such as wait times, locations, choice of providers, in order to help them inform their decision-making. This is a central focus in our strategy and an opportunity to tap into our connectivity as a health system and more fully use the digital tools that we have available now. This year, we reached a significant milestone in that more than 10,000 e-consults have been completed across our health system, helping reduce patient wait times and freeing up capacity for those who actually need an in-person care. Telehealth services like e-consults are transforming how we manage access, and we're continuing to expand this offering into pediatrics and pediatric subspecialties this year. We're also seeing results through our Refer Back initiative, which safely and sustainably transitions patients with chronic conditions from specialty care back to their primary care physicians. So far, approximately 1,300 patients have been transitioned, easing pressure on specialty care while strengthening continuity for patients. Before I close, I also want to acknowledge that there have been instances in this past time that I've been here that have tested the trust our communities and this board, all of you, have in us. We've taken those moments seriously, and they've influenced our work. We're committed to being a stronger partner, more transparent, more collaborative, and more focused on delivering results. The hospital budgets we're presenting reflect that commitment and our intent to move forward in a way that earns continued confidence. We also appreciate the joint work with members of the Green Mountain Care Board, our independent liaison, Mike Smith, and our trustees to identify additional areas of opportunity to reduce costs within our system. We feel positive about the progress this group is making and look forward to reviewing the consultant recommendations with all of you. We believe it will lead to more savings benefiting Vermonters. Building a more sustainable and affordable healthcare system will require continued partnership, one that's grounded in mutual trust, accountability, and a shared belief that progress is possible when we work together. We come to you today in that spirit, and we welcome your questions. If there's information we don't have at hand, we'll follow up after this meeting. Thank you for your time, your consideration, and your continued collaboration. Now I'll turn it over to Rick Vincent, our System Chief Financial Officer.
Good morning. I appreciate the opportunity to speak with you today about our hospital budgets for the coming fiscal year. Before I dive in, I want to take a moment to acknowledge and express my appreciation for our working relationship with the Green Mountain Care Board, and particularly your staff. We meet with your staff regularly, and they've been great to work with. The relationship between the regulator and the regulated is sometimes tricky to navigate and remain truly objective. But what I've seen this year has been a high-level commitment to responsivity, collegiality, and a commitment to work through complex issues respectfully. All of this is a testament to how deeply we care about addressing Vermont's healthcare challenges. To do our part to address affordability of healthcare in our region, we committed to submitting budgets that complied with the board's FY26 guidance. We've done that. Each of our Vermont hospital budgets meets the board's guidelines for net patient revenue, operating expenses, and commercial insurance rates. Meanwhile, we took the hard look at what we could do to reduce expenses without compromising patient care. When you hear me, when you hear us speak to how proud we are of these budgets and how difficult it was to come within these parameters, it's not to take credit for what you've laid out in guidance or for what the legislature passed this year. Quite the opposite. It's our pride in our people for doing the painstaking work to eliminate expenses while limiting the impacts on patient services. Against that backdrop, there are several considerations I want to highlight today because they have implications not only for our health system, but also the long-term healthcare resources available to Vermonters. Overall, as we built these compliant budgets, we did so with 3 goals in mind as directed by Dr. Epen. First was to provide high-quality patient care, the highest quality patient care that we can. Second was to accelerate our efforts at addressing the rising cost of healthcare in our region. And finally, to protect access to care. I first want to address affordability and some of the related factors we know the board and members of our community have expressed interest in. Our health system's administrative shared service expenses are one of those items. Over the past several years, we've made a concerted effort to reduce our administrative shared service expenses, which account for 12% of our hospital's budgets, with the remaining 88% focused on local operations. When considered as a percentage of total revenue, which helps us to compare ourselves against like organizations, our administrative shared services have gone from 13.3% in FY22 to 10.8% in our FY26 budget. This places us below the Centellus 11.2% median for healthcare organizations of similar size. When you apply just inflation to our FY22 costs, not taking into account new systems we've implemented, or the growth in patient volume since that time, our FY26 administrative shared service budget is more than $22 million less than it was in FY22. Additionally, it's worth noting our recent workforce reductions focused on our administrative shared service departments, specifically those that were furthest from our efficiency benchmark. Despite those difficult decisions that impacted our colleagues, more work remains. We will continue to further optimize our administrative shared services in the months and years to come. Another point of interest concerns the finances of our New York partner hospitals. We understand the concern about how our New York partners impact our healthcare system in Vermont, and we are happy to answer any questions the board may have. It's important to note that for FY25, our partners in New York are making significant progress towards sustainability. Champlain Valley Physicians Hospital is on track to be close to break even for the second year in a row after significant losses in fiscal year 22 and fiscal year 23. And we expect Dallas Hyde Medical Center to achieve a positive margin also for the second year in a row. Elizabethtown Community Hospital has been generating positive margins for several years. Meanwhile, Vermonters continue to benefit from our health system New York partners. Since 2015, $316 million has come into Vermont when you combine the margin impact, provider tax, and matching federal funds from New York patients seeking care at the University of Vermont Medical Center. This compares to $120 million in investment in our New York partners over that same time period. Finally, I want to speak to our system's financial reserves, which have come up frequently over the past many months. At the end of June, we have 131 days cash on hand, which is below the benchmark of 175 days for an A-rated system. As a nonprofit system, we have limited resources to bring to bear in the event of unforeseen circumstances, and we've had no shortage of those in the past 5 to 6 years. For example, in 2021, UVM Health Network had 179 days cash on hand when the national workforce crisis hit our health system following the pandemic. We relied on our reserves to maintain staffing and minimize disruptions to care, and in 1 year, our days cash on hand plummeted to 116. If we lost that same amount today with 131 days cash on hand, we would likely violate our bond covenants. Our reserves are one of the few resources we have to help ensure stability in difficult times, providing an essential backstop to guard against possible disruptions to healthcare services. All of our efforts reflected in our budgets have been focused on how to drive affordability for Vermonters, while avoiding impacts to care our patients depend on us to provide. Some will say that these cuts and the progress we've made aren't enough, that we should do more. Given the delicacy of the healthcare landscape in Vermont and across the country, it's imperative that we approach changes to our health system thoughtfully, especially when there's potential for unintended consequences to inadvertently impact patient care. I've been at this a long time and know firsthand it's far easier to dismantle or break something than it is to rebuild or build anew. Our expense reductions were significant, but we are keenly aware that there is more work for us to do to address the rising cost of healthcare in our state. We are committed to work as a health system with our partners in the state and with all of you to do whatever we can to make high-quality healthcare more affordable and accessible to all Vermonters. The need is more pressing than ever given recent changes at the federal level. Though compliant with the board's FY26 guidance, our budgets do not capture nor address the tremendous challenge we are continuing to map out, from federal cuts to Medicaid, the potential impact of sequestration, the potential loss of advanced premium tax credits, or the payment rules CMS has been introducing over the summer. We already know that these cuts endanger thousands of Vermonters by putting their health insurance at risk. But the true scale of these cuts' impact on our patients and our hospitals remains to be seen. We know that we're going to have to be even leaner and likely respond to these cuts with more efficiencies and cost-cutting measures in the months and years ahead. At this time, by now, we already know that the true FY26 Medicare reimbursement rates will be lower than what we have budgeted for, and that we will have to find additional ways to offset this to meet our budgetary targets for FY26. Looking to the future, our goals remain the same: to provide high-quality care to those who need it, to make it easier to access and more affordable. We've cared for generations of Vermonters and people around the region, and we want to keep doing this for generations to come. To achieve that, we cannot take our eye off the sustainability of what we do and how we do it. Our financial stability is critical to the care we provide, especially when it comes to strengthening access and maintaining and reinforcing our quality of care. Whether it's our operating margin or maintaining necessary days cash on hand, the organization needs appropriate financial resources and depth to take care of patients and achieve its mission. This is why maintaining sufficient reserves and a positive rating for our debt are so critical. I look forward to working with the board and its staff to address our shared challenges, and I firmly believe that despite the headwinds, we can build a healthcare system in our state that stands as a model for rural healthcare around the country. Thank you, and I'll pass to Dr. Harrington for his remarks.
Thanks, and I'll open with sincere appreciation for the opportunity to speak with you today. I serve in the position of UVM Health Network's Chief Physician Executive and President of the UVM Health Network Medical Group. And I'd like to take a moment to describe our medical group and our network departments and the power of bringing clinical expertise together in a comprehensive specialty organization. We're comprised of approximately 1,200 physicians, 600 APPs, and operational support staff across our ambulatory clinics, spanning all 6 of UVM Health Network's partner sites of care, and we directly support and staff many other sites and agencies across the region. While I've served in this role permanently for just a little more than a month, I do have significant experience both clinically and operationally within our network. I continue to work clinically in the emergency department at the UVM Medical Center, and for the last 8 years, I led the Network Department of Emergency Medicine. Emergency medicine is one of our 14 integrated network departments, and a major part of my current role is to lead the chairs who oversee these network departments. As you know, the success of the network and our partner hospitals to meet our budget targets is largely dependent on our ability to deliver on our operational goal targets. It's imperative that clinical voices and clinical leadership help lead us to build and deliver on sustainable plans for Vermonters to receive the healthcare that they deserve. And the medical group must and will keep moving in this direction. Today's about the budgets for our network partner hospitals in Vermont. So I'll focus the remainder of my comments in this opening on the interface between the medical group and its network departments and our budgetary aims for the coming year. And to that end, I'll speak to 5 categories where the medical group must deliver in FY26 that are all directly critical to improving access with urgency toward affordability and quality. Recruitment, retention, improvement in provider productivity, distribution of clinical services and expanded modalities of care delivery, and driving efficiencies in clinical care. First, recruitment. Although this may be obvious, the first may be the most important. To improve access, we must recruit more providers. As Sunny mentioned, thanks in part to our provider recruitment department within the network and focused effort from our chairs and clinical leaders, we've seen a significant uptick in our success in recruiting providers recently. We continue the strategy of recruiting and credentialing providers to deliver care at multiple sites, including at sites in Vermont outside the UVM Health Network. Providers serving at multiple sites creates resiliency in our staffing and decreases their dependency on locums providers, an area of budget reduction in FY26. We have more work to do, but the momentum is increasing, and we know we need to accelerate. Second, retention. Equally important to recruitment, we must retain our providers. This is both a business strategy and a commitment we're making to our people. Look, Vermont's an amazing place to live and build a career in healthcare, but our providers are not immune to the pressures that are being experienced across the nation. The administrative burden and non-patient facing portions of these jobs have dramatically increased over the years. And it's well established that feeling undervalued by our organization or our community contributes to emotional exhaustion, which leads to attrition and suboptimal patient experience. Similar to what we experienced over the last 5 years with nursing, recruiting and retaining providers in 2025 is a national competition, not a regional one. And the supply and demand mismatch continues to accelerate, particularly for our physician workforce, further increasing these pressures. To that end, to improve retention, the medical group's listening to our providers and turning attention across the entire network to improving administrative efficiency and transparency, looking at staffing and resource allocation, improving our recognition for frontline clinical staff, improving the engagement of our APP workforce within network departments, and enhancing efficiency through the power of our electronic health record system and other IT support and infrastructure. Third, improvement in provider productivity. As an organization, we recognize there are productivity concerns across the region within our medical group. The UVM Health Network Medical Group and our clinical leaders accepted the challenge to address these concerns and improve this metric in the FY26 budget in a realistic manner that, while assertive, is achievable. Traditionally, and in most markets, motivations to improve productivity are directly tied to desire to increase professional revenue. However, we know that provider productivity as measured by work RVUs per clinical FTE can also be considered a proxy for access and efficiency in American healthcare. We know that the measurement's inherently riddled with challenges, and we also know that there are blunt instruments to improve that metric that generally mean do more with less or spend less time per patient. Using these as singular strategies will fail our patients and our providers, none of whom want to spend their time thinking about WRVUs, and all of whom want to improve patient access. Similar to our strategy and retention, for improved productivity, we'll use the strength of the network to make it easier for our providers to get to their patients, make it easier for our patients to get to our providers, and improve how all our providers are spending their time. Our continued work to standardize clinic schedules is one aspect of this. In our FY26 budget, we're investing in a team to work with clinicians to continue to standardize schedules across the entire practice. We've already done this in primary care, which helped open visits for new patients, as well as endocrinology and cardiology. Standardized schedules allow us to leverage our electronic health record, giving patients agency to schedule themselves into UVM Health Network clinics, increasing our primary care providers' capacity to take advantage of enhanced referrals and e-consults, increases the ability to triage questions from e-consult when appropriate, to assure the right testing be done before provider visits, creating efficiencies for both our patients and our providers. Fourth, distribution of clinical services and expanded modalities of care delivery. While there are obviously common healthcare issues in our communities, it's also true that the needs of individual communities are unique. Our FY26 budget counts on us to keep patients closer to home and/or in lower cost of care settings. Examples include expanding our ICU capacity in our network community hospitals with critical care capacity to offload the UVM Medical Center, partnering the medical group with our regional non-network partners, increasing care opportunities in New York for New Yorkers, improving pathways for ambulatory and outpatient management of urgent conditions, expanding our telemedicine capabilities, increasing the capacity of our palliative care teams in home care and in our own and non-network regional skilled nursing facilities, and creating sustainable operational pathways to provide inpatient care and lower cost of care settings. All of these and more, driven by the network departments of the UVM Health Network Medical Group at all 6 of our sites, will help us meet our census targets while reducing the aggregate expense associated with care delivery. Finally, driving efficiencies in how care is delivered is a key aspect of healthcare transformation. As submitted in our budget, our clinical efficiency work represents approximately $60 million in expense reduction and is part of a multi-year process to increase the affordability of clinical care delivered by UVM Health Network. To simplify, we're seeking ways to increase access to care while maintaining or reducing the direct cost of that clinical care per encounter and improving or maintaining quality. Our medical group leveraged our frontline workforce and clinical leaders to collect ideas from their observations and their daily work to meet these aims. Ideas came from all over our network, from our physicians, APPs, and other team members who live and experience and identify these opportunities for increased efficiency. We analyze these ideas for feasibility and impact, catalog those that we plan to pursue in the future, and are acting on those we prioritized. Our initial analysis focused on care variation at the patient encounter level, for example, variance from national metrics for expected length of stay. We also focused on expense variation across our individual providers or units of care and looked again at best practices regarding care delivery decisions such as test utilization and standardization of equipment. We have many of these projects that are being implemented currently and more planned through FY26. And I'll be clear on this next point. The dollars associated with this work in the budget are aggressive and they are also real. If we're to transform healthcare with urgency, we need aggressive goals. We're proud of the clinicians in the UVM Health Network Medical Group who serve our communities. They're your neighbors, and they need to be engaged directly on solutions to their community healthcare challenges. I'm grateful for the work put into our FY26 budget, which is a result of a shift in our thinking and the opportunities before us. We believe it's imperative that all providers in Vermont, not just the ones in UVM Medical Group, have not just a voice at the table, but a hand at the wheel. And we're confident that we're in a position with our integrated network departments to harness our strength to bidirectionally share information, rapidly adopt best practices, and support our entire state and region, and not only improving healthcare access, but doing so with an urgent emphasis on affordability and quality. Thanks.
Chair Foster, I know we're right on time. We're just gonna keep moving over and we'll start with our University of Vermont Medical Center, as I understand your schedule.
That sounds good. One question, Mr. Sutter, did you want to provide an overview prior to their presentation, or would you like to just do it after? I think after is fine.
I think we can do it after or before. It's fairly quick. It's just going over their benchmarks like we discussed last year at the preliminary analysis.
Okay, we'll do it after. Thanks, Dr. Eapen. We'll turn to UVM MC.
Thank you, Chair Foster and the Green Mountain Care Board members. Jen, yeah, thank you for our slides. So next slide, please. So we're going to give an overview of the numbers for our budget presentation this year, changes to structure and service lines in 25, and then variations compared to budget. Next slide, please. So at the medical center, we employ more than 8,500 people. We're the largest private employer in the state of Vermont. We have 562 licensed acute care beds. We serve about 1 million patients across our region. We have more than 1,100 employed providers and about 1.3 patient counter and care encounters per year. 30% of the current MDs across the state of Vermont, not just within the network, were trained either as medical students or residents through the UVM Medical School and the UVM Medical Center. It's a critically important resource to making sure that providers across the state choose Vermont as where they're going to practice. We had almost 70,000 emergency department visits. I'll just tell people that when I came back in 1993 to Vermont to practice here, we saw about 32,000 patients in our ED. So well over double that number over those 30 plus years. Next slide, please. As Dr. Harrington already noted, recruitment is critically important right now for us to help work down our backlogs and improve access. We've hired 88 clinical FTE providers, 59 physicians, 29 advanced practice providers in crucial areas where we have long delays in access to care: GI, dermatology, family medicine, endoscopy. In 25, we were able to add 1,700 new patients to our primary care panels. That's 1,700 more patients who now have a primary care provider and access to a physician in primary care, as opposed to having to use the ED or urgent care for their primary care needs. Dr. Harrington also hinted at this. E-consults are a critical part of improving access and affordability for Vermonters. We increased by more than 10% the number of e-consults last year. And 80% of the time, the e-consult, when the primary care physician fills out the form and asks the specialist for advice, 80% of the time that can be handled by an e-consult. That's cheaper for our patients, it's cheaper for our private insurance companies, and it improves access because it leaves those appointments that are now available for people who do need to be seen in person. A huge improvement. We also have an enhanced referral program. 43% of adult and 14% of pediatric specialties have a form that can be filled out that helps get the answer quicker for our patients. Next slide, please. In 26, we have operational plans to further improve work RVUs and clinical FTEs, to improve scheduling, digital tools to improve efficiencies, and clinical FTE standardization across the medical group. We've also reduced internally funded non-clinical FTEs by 18.25 FTEs, which basically frees those providers up to see more patients per year to be more clinically productive. Next slide, please. I actually want to hint on just a couple more things before I hand it over to Judy Peakley. UVM Medical Center, through last year, was a 5-star CMS institution. We were proud of that. It was very hard to get there as part of the original work to get us to 5 stars. And we do know that there's a lag in terms of the data. So we maintained 5 stars through the pandemic because there's a 2 to 3 year lag in when the data shows up. When we presented to you last year, we had slipped to 4 stars. That's because we were seeing the early data in the pandemic. And this year, as we present to you now, we're 3 stars. All the data that we show in this year's 25 update to CMS occurred in 22 and 23, and all the data for 26 is already completed for CMS stars. At the beginning of 25, we fully recommitted to the UVM Medical Center and actually the entire network being a 5-star system. The medical center should be 5 stars, and we are completely committed to getting back there. We do have a closer term tool that shows us true data over 25, so it's more timely than CMS stars. It's called Vizient, and all 126 academic medical centers in the country submit the same data they submit to CMS to Vizient for ongoing rankings. The UVM Medical Center, for the first 3 quarters of 25, increased our quality scores more than 33 points. We climbed over 33 other institutions, which is the first step in getting us back to 5 stars. That data won't show up in CMS stars until 27, but we do know that if we keep that improvement going, 33 for 25, 33 spots again in 26, that should get us to 4, and then ultimately get back to 5, which is where we should be. At the medical center in 25, our CLM teams, which are our leadership teams, focused on rounding, back to basics for all providers, hand washing, very, very focused on health-acquired conditions, and daily and weekly leadership rounding. We are making progress. Next up, I want to just hit on patient safety. So the medical center needs to be safe for all of our patients to receive care. That's quality, that's avoiding unnecessary acquired conditions that happen in the hospital. I've already hinted at that the important work there of making sure that we have no unnecessary infections, falls, injury prevention, etc. For our staff, it's safe. We want to make sure the medical center is safe to provide care. In 2025, we had 98 injuries to to providers and staff, which is still way too many, but that compares to 230 in 2024. We are seeing a reduction in staff injuries. We trained more than 1,100 employees in 25 in violence prevention and de-escalation, and we are completely focused on getting our staff injuries down to zero. That's our goal. Access. Dr. Harrington touched on access. In 2024, we had 7,945 patients waiting for colonoscopy. Through hard work in 25, the current number is 3,098. We've made huge progress in getting that backlog down. We need to get back under 1,000. We're working there, and ultimately we'd like to get it down so people can get scheduled within a month or two. We're not there yet, but we are working on it. We delivered 13,000 more ambulatory visits across our clinical practices in 25 compared to 24. Provider productivity increased by 4.3% in 25. Office visits, as fast as we increase access to office visits, we are seeing the demand go up. So in 25, if you look at our wait times for new visits, it's about the same as 24, but that's because the denominator continues to increase. More people are requesting our services, which is why it's so important to improve productivity and to improve efficiency of our providers. Affordability is a major focus of the medical center and the network. I just want to hint on a couple of big projects that we are planning to open in 25 will reduce the cost of care for the patients that we serve and our insurers. Projects like ED observation will be cheaper for patients to get care there than being admitted, and it'll be cheaper for our commercially insured patients. E-consults are another major way that we can decrease the cost of care for patients. An e-consult is cheaper than being seen by the specialist in person, and typically much more quick. It happens much more quickly. As Dr. Harrington hinted at, medical group clinical efficiency is really important. That is another way we can decrease the cost of care. Appropriate testing, studies, and visits will drive down the cost of care, but maintain high quality care. I'll finally just touch on our CHNA for 22. The areas it was focused on was access and integration. We've had mental health services embedded in primary care for the past 2 to 3 years. It's really a game changer for our patients who need mental health services. They can oftentimes be seen the same day or almost always within the same week. That improves the efficiency of their care and the coordination of their care. We've done cultural and humility training at UVM Medical Center for all of our leaders, and now rolling out to staff. We have food pantries in our ID clinics and PEDS clinics. And lastly, I'll just touch on our employee engagement survey. We've been doing an employee engagement national survey for the past 3 years. The network and the medical center have been seeing improvements every single year over the 3. This last year, the medical center's overall engagement score was 3.91, which is a significant increase compared to 24. We improved in all 12 categories of the survey, and 56% of our 8,500 employees took the survey. I'm going to stop there and hand it over to Judy Peak-Lee to go over the financial component of our presentation. Thank you.
Thank you, Dr. Leffler. Thank you, board members of the Green Mountain Care Board, Chair Foster, and the staff for Green Mountain Care Board. Thank you for the time that you've spent with us working through the attempts to impact affordability while increasing our quality of care. On the screen before you is one of the areas in which we wanted to discuss our variation from our 25 budget to projected. And I will note that in our 25 budget numbers, they are what's in adaptive, and during previous hearings and work with the Green Mountain Care Board, there are adjusted numbers that you will see once we get to slide 10. The important areas to focus on here is really what we discussed in our mid-year, which is our increase in our line of NPSR, and I'll also touch on our other revenue and then the related expenses. So in terms of our revenue, it's really about demand. You can see our utilization, high demand, high patient needs. Those are really something we continue to play catch up with. We have patients that UVMMC treats that are not treated anywhere else in the state, and their demand for our specialty services is not decreasing. So you can see I listed radiology, cardiology, peri-op, but there is a detailed information around our volumes that has been submitted and provided to the staff for Green Mountain Care Board as well as to the board. Our other revenue line is primarily our retail pharmacy, and we've got more information in our slides to go into detail there. What we're seeing in terms of expenses is when patient demand increases, so do the resources needed to manage that demand. So you see an increase our salary, wage, benefit line, and that is driven by the need for additional nursing staff, support staff. We did have to rely on some physician and APP locums, and we have had higher medical and pharmaceutical expenses for our own employees, which you can see in our fringe line. And our med search supplies, which is a component of non-salary there, are higher volumes, specifically in cath lab, and getting more complex cases in peri-op. Those certainly drive our supply costs. Other parts of non-salary include our pharmacy expenses, and we've got, again, more detail of what is driving our pharmacy expense, a little note there about our chemo and non-chemo drugs based upon our patient needs. Other pieces of that, which is not impacting our commercial rate, but does go hand in hand with the largest piece of our other revenue, is our retail pharmacy drug expense that is more than offset by our retail pharmacy revenue. And then provider tax is a component of that because it is a function of net patient service revenue. Moving on to our next slide. This is the summary of what we have provided in our submission. It is a reduction in our current commercial rate by 7.9%. There is a 2.2% net patient revenue increase, which is below the guideline. And then our 3.2% operating expense growth is, for full transparency, listed there at 3.2%, but there is the carve out or exclusion, which is exempt per Green Mountain Care Board budget guidance. And without the provider tax, then we are under the guidance, coming in at 2.9%. Moving on. This is what I said in the earlier slide about crosswalking some of the items that have changed during the fiscal year 25. You can see that 1.9 billion did tie to our earlier slide, and that was what came from adaptive. However, in other meetings with the Green Mountain Care Board staff and also the board itself, there was a difference between the budget order and adaptive. We've outlined that here at 19.8 million. And then per Schedule A, in which we submitted earlier this year for CVHO, Dr. Unger patients transferring over, you could see an additional revenue impact of 20.6 million there, bringing us to an adjusted base for which we started our FY26 budget. So FY26 budget is actually 2.2% above the adjusted base for FY25, so well within budget guidelines. That's listed there at 3.5%. The expense section also has similar adjustments, including the CBHO Dr. Unger patient base expense expected of 19.4. That provides us with the adjusted expense base for FY25. And when you adjust that for the provider tax, you can see that we are actually coming in at 2.9%, which I referenced earlier. Moving on to the next slide, I do want to talk a little bit about our budget changes from our FY25 projections and what we have modified. One of the areas that you're going to see in terms of a reduction is actually in our other revenue. And the other revenue is really related, as I've mentioned previously, primarily to our retail pharmacy. And with that, what we're seeing, retail pharmacy, specialty pharmacy areas, what we're seeing there is changes over to some biosimilars. And so what that does, it impacts our revenue and our expense. It is lower cost and lower revenue. So that flows through. That's our primary area within other revenue. In terms, we've already covered our gross patient service revenue. We'll get a little bit more into the deduction section and our net patient service revenue a little bit later in the presentation. In terms of our expense changes, the main driver has to do with salaries and inflationary increases for staff and providers. Also driven on an increased line is our payroll tax and fringe. That again has to do with our movement from travelers over to employed FTEs, and I do have an FTE slide in which we'll walk through some of that additional changes there. Our non-salary expense, you can see a decrease there, and we have a slide on what some of those initiatives are to bring down expenses. So you can see that we are coming in with a positive margin from operations, which we talked about earlier with the health network, the criticality of ensuring stability for not only our organization, but also the whole state of Vermont, to ensure that the precious resources and the treatments that patients need are able to be delivered. Moving on, we'll actually get a little bit deeper into our patient care revenue and the assumptions that we have related to that. I will say on this slide, it is important to note that this was submitted prior to the Medicare final rule. And when we look at how our net patient revenue rate increases were to be distributed, the Medicare numbers are out of date. With the final rule, we are estimating that our revenue from Medicare will actually be 7.5 million less than what has been reflected in the presentation that you have and in our budget submission. We have no offsetting increases for Act 55. We've not done any offsetting related to that. So you can see how we've distributed our commercial rate reduction, not anticipating any Medicaid increases. And again, based upon final rule, the net revenue assumptions in here for Medicare are actually outdated and overstated. Going to the next slide. Wanted to give you a little bit of insight into what we're looking at for volume and where we're trying to ensure that we are looking at volume and where it can be done for the lowest cost of care. So you will see our budget is slightly down on our discharges, which is a result of admissions into our inpatient units. Our EDs do continue to be very busy. So you can see our ED visits are actually up slightly. And if you look down at our length of stay discharge days of 5.9, that is an attempt in terms of efficiency and ensuring that we continue to focus on our subacute population and finding appropriate placements for them. Earlier, it was mentioned about the increase in worked RV use for providers and provider productivity. You can see that there. OR cases are relatively flat. As is cath lab, EP. You can see GI Endoscopy down a little bit based upon what we're seeing in the latest trends. MRI, CT, ultrasound are all related to demand and orders from providers. Mammography is not down. It's actually that we've worked through backlogs. We allow our patients to self-schedule. So we're looking at what the anticipated volumes would be in our mammography. Of course, any of our areas in which there are urgent needs or increased in demand, we're not turning patients away. We will meet that demand. We will meet with the Green Mountain Care Board. We will walk through it and talk about it, but we don't have any plans to reduce care for our patients. In our next slide, you're just going to see a snapshot of our case mix index. And again, what we talked about previously, Rick Vincent mentioned our cash on hand and our coverage for our debt service. So you can see in the case mix index, we have seen a slight uptick in our case mix index. This is impacted by our number of custodial and subacute patients. So when our subacute patients are in-house, they have a very low, if any, case mix index. And as that population has been properly placed into areas that would better serve them, then the dilution of that is actually removed. So we are seeing a slight increase in our case mix index as a result of that. Also, as a result of some increased services around cancer care, such as CAR-T. Again, repeating, there's our operating margin. This is where we're reflecting days cash on hand. This does not include the $7.5 million estimated reduction from Medicare. So again, that's a slightly higher number than what we're now expecting. Moving on. We're working really hard and have done a significant amount of work inside of communities as well as in our own placement on our intranet to educate people about the options that they have around financial assistance, which here comes into the line of free or reduced care. So we're working hard to reduce the bad debt and engage our communities. Our website now has multiple language options for people to be able to get that information in their native language, a natural language. So with that, we are anticipating some shift from bad debt over to assisted care, and you can see those numbers here. All right. Then if we move on, this is just our payer mix trend, not a significant movement in that. You can see where we are with Medicare, Medicaid, major commercial, other. And we have also broken out Medicare Advantage at the bottom because the trends in that does make a difference in terms of what we look at for administrative burden, what we have to do for prior auths, and denial appeals. So it is important to understand how much of our Medicare business is actually Medicare Advantage. Taking a look at the next slide, we'll see a snapshot of where we are on commercial rate, 7.9% decrease, and a charge master increase by budget guidance of 3%. Our commercial rate decrease is broken out on this screen. We've also provided this information to the staff as well. There are many charts and many documents out there for NPR, for all of the decreases that we have anticipated here on rate enforcement at 55 and the mid-year rate decrease that we recently met on August 6th with the board and staff to discuss. Next section will be our other revenue, which I referenced previously. to show you the impact on our retail revenue up there. And our gross margin is really, again, about our changes to biosimilars. And also for our 340B pharmacy is actually in regards to our new arrangements that we have with other participants with our retail pharmacy. More details is available at request, or several of those items are actually in our narrative as well. In terms of expenses, obviously for healthcare, one of our biggest expenses happens to be labor. We are very pleased to see, and you'll see it in some of our slides, that our travelers are coming down. They're coming down faster than we anticipated in FY25. I will say that that is very positive to be able to offset travelers with new nursing staff, new support staff, and others. There is a cost to that. So while you're training new nurses, you do still have to have some travelers covering, because new nurses have to go through orientation. We have to ensure that they're fully trained. So you do end up with a rise in the cost of care because of the overlap and the insurance of safety. So it's critically important that we do have that time, but there is training and orientation expenses that go into onboarding of new staff. Other components in our staff FTE numbers, again, deal with Dr. Unger, CBHO, bringing in and caring for the patients there. So we've got a full FTE breakout that has been provided, and also details every area in which there are changes to the FTEs. In regards to the payroll tax and fringe line, couple components there. We are seeing an increase ourselves in our own utilization of health and RX benefits. In addition, travelers do not receive benefits. So in our FY24, FY25, there are not as many employed FTEs in those, and we are seeing an increase in our direct employed FTEs and a reduction in travelers. So employed FTEs are now eligible for our benefits. So our paid time off, our health, our retirement benefits. So we are seeing an increase in that line as well. Next slide just shows some of our inflationary impact and where some of that is coming from. At the time of the submission, nearly 63% of our FTEs were represented by a bargaining unit. And these are FTEs, they are not headcount. So I think it's very important to understand that, and that you can have more people than you have in FTEs based upon the way that FTEs break out. If you have a part-time, you have a per diem. And what we referenced in the very beginning of the number of employed staff that we have is based upon actual headcount, how many people are impacted by employment. The next one shows our drop in traveler. You can see that we were budgeted for 261.9 for 25. We brought that budget down to 144.8, and we are currently running about 199. So we are well on track to achieve that. Again, it is important to understand that we do have to train permanent staff, and there is some overlap with our travelers to ensure that we have good patient coverage. In addition to the numbers, there's also traveler rate reduction on the next slide. You can see that we are experiencing, as of May, you can see the rate that we're experiencing there and what we're budgeting in FY26. I will say that those rates are higher than what we had in 24 and 25, but there's also been a change in the availability of travelers that's driving that rate. Still significantly lower than during the pandemic time. In addition, the rates that you see on the screen do not get paid to the actual travelers. They are paid to the vendor, and those rates also cover transportation and housing, and they are not included in our benefits. Coming back around to pharmaceutical expense trends, just wanted to show you where we're seeing increases in our pharmaceuticals. This is not retail. This has nothing to do with that. This has to do with cost of care for our patients that we care for. So you can see the increase in our chemo and non-chemo drugs there, and you can see the trend lines that we're seeing for upticks in the cost of pharmaceuticals. Next slide. You can see these are some of our major cost-saving initiatives, our traveler expense reduction, administrative expense reductions, and then some of our cost of care reductions. I will point out that the traveler expense reduction does have some offsetting increase in our actual employed staff. So we're netting about $8.5 million off of the anticipated traveler reduction. That takes care of our financial overview, and I would like to turn it back to Dr. Leffler for our closing slide and also closing statements. Thank you.
Thank you, Judy. Thank you, Green Mountain Care Board, for your attention to our budget presentation. In summary, our total rate reduction with the enforcement from 23 and the changes from the legislature H55 is a 7.9% commercial rate reduction. It's a 2.2% net patient revenue increase and 3.2% operating expense growth, accounting for provider tax. This budget will allow us to improve access to care, continue our hard work on returning to 5 stars as a quality healthcare provider, focus on affordability in projects such as efficiency of providers, ED observation unit, getting patients to the right location at the right time. And so thank you very much. We look forward to your questions and working with you on this budget over 26.
Thank you, Dr. Leffler and Ms. Peakley. I'll turn to Mr. Sutter for the staff overview of the budget.
Thank you, Chair Foster. Give me 1 second to get this on Teams. Right. We just have a quick overview of their benchmarks. We alluded to this last week in the staff's preliminary presentation, so we thought it would warrant a follow-up. Our attorney Mark Hensler is going to walk through the benchmark section just to provide a quick overview so we're all on the same page about our benchmarks.
Hey, good morning again. I'm going to walk through briefly before Matt and his team get into performance relative to the benchmarks. I just want to go over what these benchmarks are for, how the board uses them, and how they relate to UVM Medical Center's settlement agreement with the Green Mountain Care Board. So as a starting point, this is a high-level reminder that the Section 1 guidance benchmarks for all hospitals to meet this year: NPR growth no greater than 3.5, commercial reimbursement rate growth no greater than 3%, and operating expense growth no greater than 3%. And another overview of what we discussed in the prior week, and I think we even talked about it the week before when we were doing the hearing on waiving some hospitals from hearings. So in guidance, the explanation for benchmarks is that each hospital's budget request will be reviewed by GMCB staff, and staff will use this decision tree for evaluating hospital budgets and making decisions, making recommendations for the board to consider. That first box on the far left is the Section 1 benchmarks, and the question there is whether benchmarks have been met or if they have not been met. And as you'll see, that question changes what the staff do when evaluating a hospital's budget. I won't go through this in detail as I did prior week, but just a note for anybody in public listening, there is a more detailed explanation in last week's recording. What I'll just point to at the far right is that once the staff recommend approval or adjustment to a hospital's budget, the board then deliberates. And what the board does when it deliberates is it considers staff recommendations and it considers its obligations under statute, and then it evaluates independently whether and to what extent adjustment is necessary. Next slide, please. Separately, there's another fold to benchmarks specific to the University of Vermont Medical Center. In the settlement agreement that was entered into between the network, the hospital, and the board earlier this year, one of the requirements for UVM MC was filing a proposed FY26 hospital budget that meets benchmarks in Section 1 of guidance. This was a settlement agreement entered into before budget submissions were due, but after the guidance was issued. And this section also details some description of the manner with which the hospital would need to break out its $20 million enforcement reduction, which it has done and which was referenced in slides that UVM MC just presented. Next slide, please. And Matt, I'll turn this section to you so you can go over this part.
Thanks, Mark. So this is the table we presented last week in the preliminary staff analysis, just showing all the hospitals in the state's performance against benchmark. You can see the medical center right at the bottom row. It's kind of small, so we'll cover the same materials in future slides here, but just for reference, we included this here. Last week we mentioned there was still some additional review we were completing for UVM's benchmarks. We had some questions about the operating expense growth, how the provider transfer is being applied, and how provider tax is being controlled for with the provider transfer. We also wanted to do some additional review of the commercial rate growth. There was an accounting change they presented that we just needed a little bit additional time to unpack. So here's how UVM, as they discussed just now in their presentation, how they've submitted their growth rates against benchmark. As Judy just noted, NPR growth at 2.2%, the commercial rate growth at negative 7.9% once you factor in all of the enforcement and Act 55 impacts, and then operating expense of 3.2%, but then after adjusting for the provider tax, they're claiming it meets the benchmark. So just really quickly looking at this, so their workbooks, how they've submitted the benchmarks in their workbooks. If you look at NPR growth, it's 4.4%, but that's, as Judy mentioned, that's just budget to budget and adaptive. And so while it appears greater than the benchmark, it's just comparing raw numbers rather than adjusting for the provider tax and transfers. So for checking against the benchmark, we also need to use the budget order, which serves as the cap rather than the submitted budget, which could be lower. I will walk through the math in a couple slides, but staff did find they are below benchmark for NPR. Similarly, for commercial reimbursement, this is just showing the maximum rate. That's how the sheet was presented. Maximum commercial rate request among Vermont insurers at 7.9. I will note, and I will get into this further, for comparing against the benchmark, we do want to exclude regulatory actions from this calculation, but in doing so, they're still below the benchmark. And then the one we still have questions about was how the operating expense benchmark is calculated. We're showing here how UVM's presented it, and we'll get into it a little bit further. Our question is just about how which year we apply the provider transfer, we control the provider transfer for. So UVMC is submitting a charge master increase of 3%. While it's somewhat confusing against the claim they're making with the reducing rates by 7.9%, it does make more sense when we see the components of the rate increase broken out in a few slides. And then we are also showing here just the figures presented in the provider transfer, which is available on our website as well. So quickly, just to go through the benchmarks and how staff viewed these, mostly the same as what UVM's presented. So this looks at the budget order, not adapted to the budget order. So you see at the top row, there's their FY24 budget order. We allowed a 3.5% increase. There was also the mid-year adjustment for dialysis, leading to an NPR cap of 1.924 billion. If we just look at the raw NPR submission, it's a 3.25% growth, but we do need to adjust for the provider transfer, which brings it down to 2.2%. These figures tie exactly with what UVMMC presented in the slide deck they just showed on slide 10. If we look at the commercial rate growth, and UVM also presented the same figures here on slide 19 just now. If we just consider the elements of their rate that are not part of regulatory compliance, the FY23 rate enforcement, Act 55, in the 25 mid-year rate decrease, or the impact of the 25 mid-year rate decrease, they're still below the benchmark. So we're seeing a commercial rate increase of 2.4% here. Mark, I think you were going to quickly walk through the budget amendments and adjustments.
I can touch on this, and maybe the next slide too is fine. So the board has a policy on budget amendments and adjustments, and that policy is incorporated into the guidance when the board votes. So this policy applies to FY25, applies to FY26. And this section of the policy is specific to provider transfer. So I just want to take a minute to point to a few items in the provider transfer policy, which are relevant to the hospital's calculation on meeting the expense growth benchmark. What's written here is that when a hospital initiates a provider transfer, a new affiliation requires the filing of a Schedule A. I'm going to show the Schedule A in the next slides, but I'll stay here for a minute. There are some other requirements for noticing, but when you get down to the sub-bullet points, there are a few items that address how the board deals with provider transfers. So first, documents must be filed with the board 30 days prior to formal establishment of the acquisition. Second, no filings will be recognized by the board for establishing a new budget base after May 1, meaning that if the acquisition or transfer occurs after May 1 in the fiscal year, then the effect of that acquisition or transfer in terms of revenue or expense will not be used to establish a new budget base for that year. Transfers occurring after May 1 shall be reported in the July 1 budget submission. And then there's this optional ability for the board to issue an updated budget order. If we go to the next slide, I'll just point to the Schedule A that UVMMC submitted for the provider transfer. This is the Schedule A. So the effective date of the transfer, June 23rd, 2025, meaning after that May 1st deadline that I referenced in the prior slide. The hospital did fill this out correctly. So just to note at the bottom, there's a requirement to fill out section 1 and 2 for any acquisitions occurring between October 1 and May 1st. For anything after May 1st, the requirement is to complete section 1 only. This is exactly how the hospital completed the Schedule A. And if you go to the next slide, Matt. Appreciate it. Here, and Matt can speak more to this if I'm missing important details, but what I just want to flag is the net patient revenue and the total operating expense for current fiscal year projection, which is FY25, and for next year fiscal impact annualized, which is FY26. So for 25, you'll see a fiscal projection of the acquisition being an increase in NPR of 7 million. And then if you go down to the bottom, you'll see a projected increase in operating expenses for 25 of 5 million. And then if you look at 26, which is that column C, you'll see the net patient revenue increase of 20 million, which is the figure that Matt just pointed to when looking at the NPR adjustment. And then you'll see at the bottom the total operating expense anticipated increase of 19 million. And Matt, I can hand it back to you.
Thanks, Mark. And just to explain why we're seeking some additional justification on how they've calculated the operating expense growth is when staff's doing it, we're applying the provider transfer adjustment for in FY26. It appears that UVM applied it in 25, which brings the benchmark calculation from our staff calculation of 3.19% to the 2.96% that they've presented. On a percentage basis, it's relatively small, but UVM's budget is large enough that the difference between 3.19 and 3% is roughly, I'd want to get the exact value, but roughly $4 million. So we will seek additional clarification from UVM on why it was calculated this way. But that's just we want to give a brief staff presentation on their benchmarks. Thank you.
Okay, thank you. I guess I'll ask one quick question. Is staff's analysis correct as to the Unger transfer being included in 25?
Judy?
On this?
Thank you, Chair Foster. Is included in the base for which 26 is built. And the reason why that is because this is not new revenue to the system. This is a movement of patients from a closing practice over to us. And in addition, you can see the very small margin that is anticipated. So the net against that is less than $1 million in what it impacts for. And again, it is intended, it was not an acquisition, it was intended to care for patients that are already in the system. And per Schedule A, we needed to include it in the base, or it would appear as new revenue budget to budget.
Thank you. All right, why don't we take a quick 3-minute break, and then we'll go to board questions. We'll come back at 10:23. Thank you. Okay, we can resume our hearing, and we'll start with board questions with Member Holmes.
Thank you, Chair Foster, and thank you to the the network and the UVM team so far this morning for your presentations. Also, I want to acknowledge and thank you for the work you have done to find efficiencies and savings in these budgets that you're submitting. So I'm going to start, I think, by talking about asking about a big ticket item. So for Judy and Steve, I want to talk about UVMMC's contribution to network shared services. It looks like for fiscal year 26, it's about $500 million in network level shared services that's charged out to affiliate hospitals. Is that accurate?
I do not have the exact number in front of me. I assume that you're looking at something that reflects that we've submitted, so I will go with that.
Okay.
Understanding not a
I'm working
direct
with the
cost.
right numbers. Yep. Okay. I think 496, I'm rounding up to 500 million.
Sure.
So could you clarify to me the budgeted amount that UVMMC will be responsible for in that shared network expenses?
So, Rick, do you want to talk a little bit about the allocation methodology before we actually get to any amount in terms of what is the philosophy and how shared services, because that is a network area in which we all benefit.
I'm just gonna, I think we can talk about that more this afternoon. I would actually just want to, at this point, I just want to understand what the number is for UVM. Back of the envelope, typically it's about 67%. So is that about right? $330+ million. Would that be about the right ballpark? We can get the exact number.
Yes, it has run about 67% in terms of yielding what the total component of covering the cost for shared services has been, recognizing that it is built based upon a total revenue percentage. So the number that you're reflecting at 67% stems from the allocation methodology on total revenue.
Okay.
So as we have the largest portion of revenue for the health network, then it does translate to the largest portion of shared services expenses.
Right. And if UVMMC's revenue grows faster than, say, the New York hospitals, that proportion of the shared savings will grow. Is that right?
It can, yes, it certainly can. The other piece of it is it may not be that shared services grows. So it's not necessarily one-to-one in terms of if there's growth in revenue areas for the medical center that doesn't require additional components for shared services to increase in cost, then their costs will not necessarily increase. We may get a greater share because we may be utilizing the services at a different rate.
Okay.
That is true, Member Holmes. I'll just add that the trend is actually this year, and Judy is actually seeing that in her financial statements. The trend is actually going in the opposite direction this year, where UVM Medical Center's proportion is declining. But to your question, yes, that is correct. If it was increasing, then the proportion would increase.
And is about 333 million the appropriate amount to be talking about for UVM's contribution in the fiscal year 26 budget?
I'd like to quote exact numbers, and I was just trying to find exactly where that is in the budget. If you give me a couple minutes, we'll have the exact number.
Okay. Well, so back to Judy and Steve. What I would want to understand is what analysis do you and your team at the medical center do to ensure that that amount, and let's call it for now 333 million, and all of the line items that $333 million supports is a fiscally responsible expense for UVMMC and ultimately the patients that you serve to assume. So what data do you look at to ensure that the contribution will generate at least that amount in value to UVMMC and the population it serves?
I will start with that from kind of an analytical component and ask Dr. Leffler to chime in terms of value. So every single month during our month-end closing, we are reviewing what types of expenses are coming through And what does that look like, not just from our perspective, from a shared services perspective in total. So we are looking at it, where is the actual spend going in and how important is that to our patients and all patients that are served by our network. So we do look at that every single month. In terms of value, Dr. Leffler, I'll let you speak to value of shared services.
Yeah, so what I would say, Member Holmes, is that the network builds a shared services budget every year, what it's going to cost to provide these services across the network. It's allocated out by net patient revenue. We have our share, and then there's a constant back and forth with the network to make sure that each individual hospital is able to get what it needs. So we've already talked a lot about quality this morning. And so we've worked very hard to make sure that quality for the medical center is going to be adequately covered in 26 to do the work that we need to do to keep our progress online. And so for every different shared service area, whether it's HR, quality, DEI, whatever the issue is, we work together with the network to make sure that, yes, we're paying our 67%, but that we're getting value back on the things the medical center needs to deliver high quality, safe, efficient care to our patients. It's a ongoing weekly back and forth to get the services that we need and make sure that the other hospitals are getting what they need as well.
Do you, since you're contributing roughly 67%, do you feel like you are getting 67% value overall from those contributions?
I would say that every hospital is working to get every single possible squeeze out as much as they possibly can out of shared services. And so we do have some heated discussions weekly, but I do think in general we're getting value, and the medical center in general is getting what we need by and evidenced by the progress that we're making back towards our goals. So I'm sure you ask each of the presidents, they'll say we'd love a little more. And that's absolutely true for the medical center. There's more stuff we'd like to be able to get out of shared services, but it's a constant, I would say, family dynamic in terms of getting back what we need from the investment that we make in the network shared services program.
Do you
I would
see?
Can I please add to that? My apologies, didn't mean to speak over to you. Is it all right if I add to that?
Sure.
Thank you.
Yeah.
I do want to say that, as Dr. Leffler mentioned about family dynamic, it's also very important for UVMMC to see that other hospitals are adequately supported as well, so that when we need to make a transfer, we need to make a placement, that they also have what they need. So he mentioned kind of looking at it holistically. We also look at that, ensuring that they have what they need to ensure that they can help the patients that we're serving if we need to transfer them back, if they need to transfer to us. So it is a holistic approach as well.
Okay, thank you. Do you think that the medical center is contributing to these shared services in any way, subsidizing IT or communications or care management or quality improvements in the New York hospitals? Is there a net subsidy going to New York from the contributions from UVMMC to network shared services?
I guess that may be a technical finance issue. What I would say is it's critically important, and Judy just hinted at this really nicely, that the patients across our system are getting high quality care where they are, can get what they need, can get what they need. And so we know that we're paying 67% of the total expense. I have someone just told me it's 329 million for 26. And that if you look at Centillus, which is a benchmark tool that we use, the academic medical center is paying an appropriate percentage of the shared services. I think in general, each hospital's paying to the benchmark that we've built, how we do it through our total revenue, or net patient revenue, I'm sorry. I think we're paying our fair share.
Okay. On the balance sheet, it does say that $103 million is owed to UVM from related parties. This is a follow-up question, but I'd like to understand exactly what is due to UVMMC from whom and for what services for that $103 million. Is that possible for you to send in a supplemental? Okay.
Absolutely. We certainly can.
In fiscal year 23, the due from line was 87 million. In fiscal year 24, the due from line dropped to 3.3 million. And now in fiscal year 25, it's 103 million. So I guess my first question is, why the huge reduction from fiscal year 23 to fiscal year 24, the 87 million to the $3 million drop on the balance sheet?
We can provide you with the flow of the of all of that year over year, and I think that will give you a much better snapshot of it. But I don't want to quote it and do that without the numbers in front of me, if that would be all right, Member Holmes.
That is fine. Can you generally speak to what is in the 103 million? Just generally, I know you're going to provide a more detailed breakdown later, but I want to understand really who that is from and to. I mean, it's to UVM, but really who is it from and for what services, generally speaking?
Rick, I see you came off mute because it represents more than just UVMMC and kind of the flow through and from for all of the hospitals within the network.
Yeah, so you'll see, Member Holmes, when we provide the details, some of it is to the UVM Medical Center, some of it is to the UVM Health Network as well. So we'll provide you the detail of how that breaks down. The services that are distributed through shared services is a component of what you see there. So it's all the administrative shared services for HR, IT, those types of things. We also pay other expenses centrally. So we pay the physician salaries are all paid out of one account. The benefit plan is paid out of one account. So we can show you that detail and break it down for you based on who owes what. And that drop in terms of the due from on that you're seeing on the balance sheet, I'd like to see what you're looking at there. We might have changed a line on the balance sheet because there definitely wasn't a significant drop like that in that due from, but we'll get you all of that detail.
Also, it'd be helpful to understand why the due from is carrying over from 25 to 26. The 103 million seems to be carrying over on the UVMMC balance sheet. So is that a recognition that there will not be a repayment of that 103 million? Or is there some other interpretation of that?
So that's a balance sheet item. So if it's essentially a point in time that we're budgeting there. So yeah, those balances carry over until they're paid.
Okay. How do you calculate days cash on hand with reference to the due froms on the UVM MCs? And actually, maybe this is a question for Judy, since Judy, you're the UVM MC CFO there. How does the days cash on hand reflect due froms, money that's owed to the medical center? Is it counted in days cash on hand or no? Due tos.
Sure, no problem there. So in terms of our due to, due from components, we actually have a centralized and our days cash on hand centralized treasury that does that calculation for all of our entities. So I think it would be important to see both where we're owed something and what is that impact to the entity that is owing, as well as if we're owing something to the network. So we'll send you kind of how that calculation goes across all of the network facilities so you can see that impact, if that will be all right.
Okay, that would be very helpful. And one more question about this in this area. How do you allocate expenses associated with UVMMC physicians who share time between CVPH and UVMMC? I understand that's more of a growing trend of sharing time between the two hospitals. So how does the allocation of that time work on the books of UVMMC and CVPH?
UVMMC is only paying for the portion of time in which the providers are providing services here.
Okay.
Anything or anytime they're providing services at another location, that expense as well as the revenue is going to the other locations.
Okay, great, thank you. this is I think just really a follow-up question, but last year you submitted a historical chart with expense per adjusted discharge and how it compared to teaching hospitals. It was part of the submission last year. It would be helpful to see in a follow-up how that chart has changed or how that measure has changed and how it's, the performance is doing relative to benchmarks again. So that's a follow-up question, if you could.
Certainly.
I
Yes.
found that helpful. I wanted to talk a bit about purchased services in UVM MC's budget. It's about $66 million in purchased services. This is also a follow-up question, I believe, but I would like to hear about a breakdown of to whom, for what, the dollar value of by contract type, what is in there. In particular, I want to understand, it doesn't look like it's not travelers, because there was a line there for travelers and that was zeroed out. So this does seem to be consulting and other types of purchase services. And I'm very interested in the purchase services around legal, marketing, lobbying. If you've hired DC firms, local Montpelier firms, I assume that ends up in that purchase service line. I'd like to understand the breakdown of all contract types, but in particular, bucketed in those types of areas. Is that possible to follow up on?
It is.
Okay, thank you very much. A question about investment income. So it looks like UVMMC is booking 0 for investment income, but it looks like the other affiliate hospitals are booking positive investment income. So I wondered why.
Well, look at that piece of it, but do recognize that, I apologize, I'm going to use the word recognized twice here, that in terms of investment income that we see month to month, it is unrealized gains or unrealized losses. That unless we were to actually sell something, we would not realize the actual investment income or investment loss. So that would come into our actual financials at any point in time in which we were to trade or sell and have a realized gain or loss. But typically what you're seeing month to month and the increases and decreases are all market dependent.
Yeah, I guess I'm trying to understand the consistency across hospitals. So I think CVMC on the income statement, it booked $1.5 million for investment income. Porter, much smaller, was I think $265,000. Overall, at the network, $6 million was booked in or anticipated in investment income. So there are segments of the network where there is investment income booked, but I had noticed that UVMC had 0. And looking back, it looked like in previous years, it was about $21 million in 2024 and $22 million in 2025 in terms of investment income. So the difference seemed significant. And also, it did seem like smaller hospitals were booking some positive investment amount.
Happy to look into that. Rick, I see you're off mute as well.
Yeah, I'm just going back, looking through time member homes. So it looks like actual was about 730,000 in 22, 4.3 in 23, 8.6 last year. The budget last year was actually a negative. So we're looking at the assumptions, I assume, is, as Judy said, we're not planning on selling any investments and there isn't much dividend income. So that line I think that you're looking at is actual interest or investment income, not the change in the value of the portfolio itself, because that line, there's a $23.6 million budget there for essentially the market value, us projecting that the market value of our investments are going to change. So we can get back to you on that assumption on why actual interest income was not budgeted there.
That'd be great. Thank you. And then also, I'm curious about this non-operating revenue, the all other category. In 2024, it was 75 million. In 2025, it's projected to be minus 36 million. And then in 2026, it's budgeted to be 11 million. So I'm really trying to understand, those are pretty wild swings in non-op revenue, all other. And so I'm just, what is in that bucket that would generate such wild swings for the medical center?
Yeah, Yeah, saying that we can get you the details. Some of that actually, how far back did you look? Member Holmes, what was the first year that you looked at
I
there?
just at 24, I was looking at 24, projected 25 and 26 budget.
Yeah, some of the pension related liabilities flow through that section of the P&L as well. I think that was all over by 24, but we can get you the detail on what's flowing through there.
Okay. I also wanted to talk a bit about the high margin services tab that was submitted, high margin, low margin. I was surprised not to see diagnostic radiology, MRIs, CAT scans on the list for high margin services. They tended to be high in other hospitals. And I wondered if you could follow up with the revenue and the margin for MRIs and CT scans in 24, and also the associated pricing markup over Medicare for those services. The gross revenue is quite high for those areas. So I was surprised not to see them as listed, broken out as potentially some of your higher margin services. Is that possible, Ms. Peakley, to follow up with?
Part of that is, I know is possible, but I will state that what we provided were actually service lines that have multiple components within them. So you could see that if it was a neurology, you could see everything that goes into neurology as a service line, which would include testing, it would include lab, it would include provider. So you could understand by service line. We consider any of our outpatient, inpatient areas like MRI, lab as a part of the treatment and part of another service line, not as an independent service itself, because tests are only ordered as part of looking for something else. We certainly have the charges. We would have some outpatient reimbursement numbers for you. Inpatient MRIs and high dollar tests like that are typically captured within the DRG and not separately reimbursable. But that is why you would not have seen it, in that we weren't looking at it in terms of volume generated. We were looking at it in terms of true service line.
Got it. Okay. Well, that'd be helpful to follow up on. I was also surprised to see that the medical center is not able to generate a positive margin on primary care with commercial rates over Medicare of 300% over Medicare. And interestingly, especially comparing that to Porter and CVMC, where actually internal medicine, primary care tended to be in the high margin services. So can you talk a bit about the inability to generate a positive margin at 300% of Medicare, roughly?
A significant amount of that would depend upon payer mix, how much is coming in as Medicaid, how much would be coming in as Medicare, how much would be coming in as commercial. So that is imperative in terms of being able to generate a margin. Other components may be around provider mix. So we can certainly look a little deeper in that to pinpoint whether it's a combination of those factors or one more than another.
Yeah, the reimbursement rates are so much lower relative to Medicare at Porter and CVMC, and I would suspect that the payer mix at UVM is pretty good. So, but it would be helpful to understand that, and I also would wonder if it's the cost allocation. Does cost allocation have anything to do with the inability to generate margin there? But follow up with that would be great.
Yeah,
I
we
do
can
want
break
to.
it. I apologize. We can break it into direct versus overall.
Okay, great. Thank you. I think I'm going to ask this directly of Dr. Loeffler. I want to talk a bit about the access to your inpatient beds. And I wanted to know if this year you've had to turn away transfers or had to keep patients waiting in the ED overnight because of inadequate staffing in inpatient units, right? You have physical beds, but you don't have it adequately staffed. Has that happened on your inpatient floors this year? And if so, how frequently?
It has happened some. It happens every year. It happened during the last heat wave a couple weeks ago, where it's almost totally predictable. If you have 3 or 4 extremely hot days, the ER is going to be very, very busy. There's going to be a number of people who have to be admitted. And so we did see a bump up in the number of people waiting overnight. I think I saw this morning, there was 2 patients this morning waiting to go up. That's relatively uncommon. As we've brought our census down to pre-pandemic numbers, we've very, very carefully tracked the number of ED boarders overnight, transfers in, and capacity to get people the care they needed. And our numbers look really strong. We've done so much work this year on length of stay, getting length of stay right, and getting people out to nursing homes in a timely fashion. And that has improved over this year. That our metrics for transfers most of the year have been above 24. And while there have been some nights where we've had some ED boarders, it's very comparable to prior to decreasing our census. I will say that we need to be very cautious as we make our adjustments on census, but we've done that work very carefully to make sure. And as nursing home beds have improved and opened up, that's allowed us to get people to the right level of care and decrease the overall cost of care and the cost of care for the medical center. So yes, there have been some nights where we've had some ED boarders. It's very comparable to previous years, and we're monitoring it very carefully.
Great. Actually, I would love to see like if there's monthly on transfers,
Yeah.
monthly data on transfers, turned down, accepted, delayed, things like that as you're thinking about staffing. And one of the reasons I'm asking this question is when I look at your staffing and the FTE by department, it looks like your med surge staffing from fiscal year 25 to fiscal year 26, you're going to be down 55 clinical FTEs. Your critical care units are going to be down 5. Your neonatal ICU will be down another 5. So as I look at your clinical FTEs in acute inpatient, it looks like you're going to be down 65 clinical FTEs between 2025 projected and fiscal year 26. But you're also increasing your acute staffed beds from 450 to 470. So I'm trying to understand how beds are going up and what I would, clinical FTEs staffing those beds seems to be going down, but maybe I'm not quite following the math here.
Certainly. So I think that's a great question and very valid to make sure that everyone is clear about how we're managing our patient needs. We are supporting other hospitals to ensure they have what they need to avoid a transfer when possible, and ensuring that patients can get what they need without the burden of a transfer. So that is a big goal for us as well, not to have to do everything at UVMMC. With that, we are looking at where do we need to enhance services. Some of those increases that you're seeing are actually for our inpatient rehab unit. There is an expansion of services there because we've seen an increase in patient needs. They'll be in the hospital and need to be placed in a rehab for continuing care. And we've seen the expansion there. We are adding staff to that area. When we look at our med surg units and we look at the combination that we've had in acuity, and we look at the reduction that we've been making in appropriate placement of our subacute or non-acute, that is allowing the census areas to come down. And we're also looking at what is the result of other services provided in our utilization sheet to see what demand is going to be on our surgical ICU, our medical ICU. What do we have in terms of demand and need in our children's hospital? And we've been adjusting staffing to that. The other piece that you'll see in our med surg units is when I was showing you the reduction in our travelers, there's been an overlap while we're training staff. We would have a traveler and staff. So some of that is a natural, as staff are coming up and getting onboarded and they're able to take a full clinical load, we're able to release the traveler. So there are a lot of moving parts in that. And I hope that gives you some sense of how we're looking at caring for our patients. We're not looking to turn away patients who truly need our help. We also are looking to relieve some of the burden on the families if we can help other hospitals keep patients there through consults and certain telemedicine, things like that.
And I'll just add a couple quick points. Thank you, Judy. Just our reduction in average length of stay has allowed us to maintain services, but decrease the number of beds that we have. Our border numbers are much better in 25 than they were in 24 in the ED. And finally, we are trying to keep people local when we can. So when you're looking at the transfer data, which we're very happy and proud to share with you, we want to get the people who need to be to the medical center right away, here immediately. I think we're very, very good at that. There are some people that it's appropriate to stay overnight where they are for multiple reasons. And there's some people now that with help from our specialists can stay both in the network hospitals or in the community hospitals across the state of Vermont. And so we've worked hard on that this year. We're happy to follow up with that. Dr. Harrington talked about that a bit in his discussion, but that is going to be critical going forward, that people who can stay close to home at any Vermont hospital with a little help from us should stay there, and we're committed to doing that.
Okay, I appreciate that. I want to make sure that people have ample opportunity to ask questions too. So I have a few more. I just want to get through them. And it relates to workforce. So in the presentation, you talked about hiring 88 clinical FTEs. I think there are 59 physicians and 29 APPs listed. But when I look at the budgets for fiscal year 25, it looks like there were 711 physicians in fiscal year 25, and you're down to 706 for fiscal year 26, and APPs fell from 314 to 307. So it looks like you're net down physicians and APPs, not net up 88.
I'm going to the slide there, recognizing what I think you're speaking to is budget to budget.
Yes.
Yep. So I will say that we were optimistic in 25, and we have had some really good success with hiring. And I know we do have some leadership on from the medical group. And we're adjusting as our patient needs are adjusting. So that's what I have in terms of contribution for the changes that you're referencing. We are relatively flat budget to budget, but we have seen some good recruitment efforts during FY25 that we think will continue to carry us over into 26. And we will look for opportunities to reduce any type of locum with a permanent position if that becomes available as well.
Okay, but you are net down from, I mean, projected you had 702 physicians, for example. So I guess I'm just, okay, understood. 88 was not, that is not net of any departures in physicians or APPs.
Correct.
Okay.
Correct. I do not think it is net, but we can double check that.
Yeah. Okay. And with respect to travelers, it does look like, and I want to talk a little bit about this because meeting the Green Mountain Care Board's expense growth benchmark relies very heavily on the ability to replace those travelers with permanent employees. And most of the travelers' savings comes from a reduction in nurse travelers. And so two things. One is you noted that the travelers' expense reduction you're anticipating is about 19.7 million. I just want to note that on page 10 of narrative, it looks like it's a $17.8 million reduction budget to budget on the traveler line. So can you explain that difference, the 19.7 that was in your presentation and the 17.8 that I see on page 10 of the narrative to meet that expense target?
Sure, I'll have to look at what the components we're comparing and give you a reconciliation back. Happy to do that. And to speak to what you said about the reduction being in nursing, you are absolutely correct. We have had success in bringing in new graduates from the RN programs. That does take a significant amount of orientation and has contributed to the higher staffing numbers that we have seen because travelers are included in our FTE counts. In 26, we are looking for that to drop. Where we have not been successful in recruiting has been in areas such as respiratory therapy. We still run a significant number, and that is to my understanding, is not unique to Vermont, but it actually is something that we are meeting on next week to see if there are any other alternatives to enhance or improve our recruitment efforts for our respiratory therapy, because that has been an area in which we have struggled to actually recruit permanent positions.
And to get from, I mean, you had 260 RN travelers in fiscal year 24, and you're projecting to get to 84. That's a very large reduction in 2 years. If
It
you
is.
can't achieve the traveler reductions that are built into your budget to meet the Green Mountain Care Board's expense benchmark, where will you find cost savings elsewhere to ensure that you're not compromising access to care?
We would certainly have to look at where we're running at the moment in time. What opportunities do we have? What changes have happened in the environment that might allow other areas to be reduced? So we would certainly look at that and keep you informed.
Can you
I would just
commit
add,
to not compromising access to care and looking in places that are non-clinical to meet that benchmark?
so what,
I myself
yeah.
cannot commit to that. I'm
So-
gonna let
Dr. Leffler,
Dr.
can you
Leffler-
commit to that?
what I would say is every budget is a plan. It's the best plan we can make as we build it. The budget was started being built in February. And so based on the guidance you give us back, the realities of the assumptions that we made, we're going to do everything that we possibly can in our power to preserve services in 26. That was the commitment we made when we built these budgets. We have to see what happens in the budget, what the guidance is, what happens from the federal government, what happens to other partner hospitals. We're committed to doing everything in our power to preserve services to the very, very best of our ability. That's the commitment I can make.
Okay, so your ability to convert those travelers to permanent really is dependent upon your ability to recruit and retain and
Yes.
the culture and employee satisfaction. So it'd be really helpful. You mentioned, or somebody mentioned, these Press Ganey, I think it was, or employee engagement surveys. It'd be really helpful to see the last 3 iterations of those employee engagement surveys so we can assess, you know, whether there really is that ability to convert that percentage of travelers and retain that many employees. So that would be helpful for in follow-up to see those.
We can send you all that.
Okay. My final question here, and I think you've just answered this, but I just want to make it sure that we have it on the record. Does your budget include any eliminations of services?
Our budget eliminates no patient care services as submitted.
Okay, and does it incorporate any reductions in services?
We may further reduce bed numbers depending on what our length of stay work is, depending on how our nursing homes are able to accept patients. That actually, as nursing homes, they were filled a couple weeks ago during the heat. That actually impacts our ability to further reduce AL or average length of stay. And so we may or may not bring our average number of beds down a little further if we can meet all of our length of stay goals, all of our quality goals, all of our discharge appropriately to partner hospitals, nursing homes, etc. We may decrease beds further or not.
But no reduction in service lines, areas, primary care, dialysis, mental
No.
health, none
No.
of that.
None of that.
My final question is, with the cap in drugs, does your budget assume any transfer of infusion patients from UVMMC to New York to avoid the cap on drugs?
Not that I'm aware of.
There's no transfer of patients for an intentional avoidance of the cap. I will say it would be advantageous for patients in that area if they could have services there. But there is nothing in the budget that has anything to do with cap avoidance. What you see in our budget is about what does UVMMC need to take care of for our patients in our region.
So that's a really important distinction. I just want to build on that. We are committed to having people get care as close to home as possible. If New Yorkers can stay in New York and get infusion therapy, cancer care, surgery, etc., it's better for them, and it's better for them to be close to home, and it's good for those hospitals. So we will try to make sure that New Yorkers, when possible, can stay in New York, and we'll try and make sure that people can stay in Barre and Berlin and Middlebury when it's possible. So that is ongoing network effort to keep people close to home. But that's different than doing it because of to avoid the cap.
Okay, thank you very much. Those are all my questions, Chair Foster.
Thank you. One procedural question. I got the sense that some witnesses were communicating with other people while testifying. Is anyone communicating with other colleagues while you testify today?
So Chair Foster, my chief medical officer did send me an update on an expense report, and so I could give an accurate answer.
Okay, great. One note, if you're going to reach out to other people while you're testifying, just flag it for us that you're reaching out to someone to get the information. Let us know where you're getting the information from. We just want to make sure the witnesses are testifying. It's their testimony. And if you need to reach out to somebody, just flag it for us and let us know. Otherwise, please don't communicate with other people while testifying.
My apologies.
No problem at all. Thank you. I'll turn to Member Walsh.
Thank you, Chair Foster, and thank you all for being with us today. I appreciate the tone of your introduction and the substantial steps you've taken so far. I want to start with some questions about operating expense and affordability. You described several specific steps that you took to keep your operating expenses within guidance this year. You outlined operating expense growth was to be about 3%. There's a commercial rate decrease of close to 8% and a 3% charge master increase. Then to lower the op-ed, lower the operating expenses, you talked about staffing reductions, reduced traveler expenses, deferred capital projects. Do you see further opportunities to decrease operating expense over time, or do you expect them to continue to grow?
The goal would always be to look at opportunities for reduction in costs. As I mentioned, the largest expense that we have is really around our staffing. What we don't want to do is, have subpar or pay poorly for our staff. That's one of the things that Act 68 talks about, is ensuring that we can attract and retain qualified healthcare workers. That's critical to delivery of care. But it doesn't mean that we won't look at opportunities for alignment of our costs with the care that we deliver, and always trying to look at how can we reduce the cost of inpatient care? How can we ensure that we're the most efficient? Efficiency is one of those that will be ongoing continuously in healthcare, regardless of where you are. So no, we are not finished. And what we have put forward is very hard. It's taking a lot of work on behalf of all hospitals, the network, and our staff. So we're very proud of what we've submitted. It will be a challenge, but it's not a stopping point for us.
What I would add is sorry to interrupt you. Do you want me to add to that, or do you want to go?
No, that's fine.
What I would add is that over the past 8 to 10 years, the network has made major investments in tools to improve efficiency, productivity, access. And we have to leverage those tools now to get the most value out of them. And so you've heard presentations say about how to use Epic to help people schedule appointments better, how to use Workday to standardize that across the network, how to use the radiology tool that we put in so that the right studies can be read in right locations. So we have to squeeze every possible dollar we can out of those systems to be as efficient as possible. We have to use tools like AI when it's appropriate to drive down costs. And I do believe that over the years, while cost for each employee that we have are going to increase, we know to be able to recruit and retain our staff, we're going to have to pay fair, competitive wages. But we can be more efficient about how we use those people so everyone's working to the top of their license, and that every tool that we have is used to make sure that patients get the best care they can for the lowest possible cost. Things like ED observation units, keeping people in local hospitals when appropriate, telehealth, e-consults, I do think will overall help decrease the cost of care. Thank you.
Yeah, sure. And thank you for the responses. I guess what I'm trying to get at, is your strategic aim to decrease operating expenses or to slow the growth in operating expenses?
I think it's both. So we've really
Well,
focused.
there'd be a difference between decreasing operating expenses or slowing the growth meaning they would not be decreasing.
Slowing the growth, when I think of that, I think of our suppliers and supply chain and what can we do to work with them to negotiate and slow the growth. So that's what I look at. And in terms of reduction is really what Dr. Leffler was talking about in terms of efficiencies and what we're using when and how do you become efficient and actually drive down cost. So when I say both, I think you have to do both because some are not within your direct control, but they are within your direct influence.
Okay, I think I understand what you're getting at. Let's I'd like to talk a little bit about the relationship between the commercial rate decrease and the charge master increase, and how you see that combination translating to improvements in affordability for Vermonters.
I'll take the high level. I'll let Judy do the fine detail. So we know that the number of dollars that'll be going to our commercial insurers overall total is less by enforcement and H55 and any other programs we adopt. We've already talked about them that decrease the cost of care for the people we serve. The payments we make overall will be lower to Blue Cross by that amount. And ideally that would translate into lower premiums for the people that buy insurance from them, however they do it. I understand what you're saying, that any individual charge might be more, but the rate of increase for Blue Cross, total amount, big picture, should go down by 8%. I'm going to let Judy, because they explain how the charge master fits into that.
Certainly, when we look at the 3% charge master increase that was allowed by guidance, we also look at that not as every single line item going across the board. It is assessed. We have a whole team that assesses our charges, and I would say that I am not the expert in how all of that flows through, but it is intended to comply with the budget guidance, and it does work in combination with our commercial rate increase. But we can certainly follow up with additional information around that because we do have a team that works on our charge master.
Kelly is wondering if we need her. Yep.
Oh, thank you. Yes.
That'd be great. It's fine to follow up. What I'm as part of that, what I'm interested in are whether there are any internal metrics. You mentioned premiums, out-of-pocket expenses, but are there any internal mechanisms you have for following up with or monitoring affordability and the ultimate impact on commercial payers? So it's fine to follow up. I want to ask a couple questions next about utilization forecasting, volume forecasting. In prior budgets, you've ultimately underestimated utilization and NPR to the point where there have been overages, enforcement, and mid-year adjustments. How should we view this year's projections where you've assumed a stable or modest growth across most service lines, but in others, there's notable increases?
So I can start with that in terms of historical and what we have today. Historical, I will say, in terms of percentages, there's been significant, I guess, little significant variance in terms of percentages. In terms of dollars, we're a large organization. Dollar-wise, yes. if you're thinking about a $20 million net patient service revenue variance, it's a very small percentage for us. It would be a large percentage for other hospitals. So I do want to make sure that we keep that in balance. The other piece of it is we actually do not have information coming in that gives us any changes in, volume of commercial people that are covered. So if all of a sudden a new contract comes in, or there's a big population that's picked up by commercial, we don't have that actively available to us. So two things that I've seen is that patient seeking services has exceeded our expectations. And so therefore, not only did revenue go up, but our expenses to take care of those patients went up as well. So both sides of that went up beyond our expectations. That I will say, I don't have a good indicator of people's behavior, and we're not fed information about any additional commercial contracts. So in terms of utilization by payer, I also don't have anything but historical and information that's coming in to determine, okay, what are we seeing? The last piece I'll add to that is timing. So when we're looking at information from October to February, we also look back at the prior year to try to get full seasonalization, but it may not capture behaviors that would happen March, April, May, June. And that's why I think it is important that we continue to look at mid-year. Where are things running? So there's no desire to suppress. We use the data that is available at the point in time in which we are building our budgets.
And one last very brief comment, just our budgets, we start building them, 18 months before the end of the budget. All of our budgets have been within 5% of the revenue growth, which I know for us being off by 2 or 3% is a very large number, but it's actually pretty amazing. You're doing your best to plan these. You don't know what services across the state are going to become less available, who's going to have issues, how hot it's going to be in July. There's a number of things that are built in there. We built our expenses off what we believe the revenue is going to be. And so if you overshoot on revenue, you'd overshoot on expenses. So I hear your concern and I understand because the numbers are big, but our budgets are actually quite close. When you think about how far out, we're trying to do our best to guess what it's going to be. Thank you.
Yeah, sure. I understand the difference between absolute and relative, and I think it is a difficult process for sure. We do see across the state that some hospitals, on a percent basis, their variance is much tighter, and others it's wide, and we're trying to understand that. And so I'm wondering if you've made any changes to improve the accuracy of your forecasting.
Always looking for improving the accuracy. I will say what's different about the academic medical center is the types of services that we provide and the specialty care. So the demand of specialty care and the evolution that we have to always be looking at meeting the needs of our patients. We may bring on, an additional cancer drug that would drive up costs or would drive additional treatment options for patients that may not be in the budget. So we are not as, I would say, stationary as some of the community hospitals because they're not looking at advancement in healthcare the same way we are. All of us want advancement in healthcare. However, being the academic medical center, that is part of our core mission to bring forward services and treatments. And that can certainly, like when we did CAR-T, that service itself is very beneficial for patients, but also very high cost.
Yep. So, I understand the uniqueness of your facility. I asked whether there were changes that you've made to improve the accuracy. It doesn't sound like there's been any, you haven't consulted externally or changed any of the models that you use to make the predictions.
No.
Well, I will add one thing that I believe we've tightened up internally in terms of our communication with providers that are coming on, what type of services, and our collaboration with our medical group has been much stronger. So that has been an improvement when we look at what services might change in the future. That is our area. I think it had been our areas of highest opportunity and one that we've really leaned into.
Yeah, that's great. Would you be able to follow up then with some documentation about the process that you use to make the volume estimates and any process that you use to validate those, particularly when if you make adjustments to the models based on prior years' results? So I'm looking for information about how you try to improve accuracy over time.
Certainly, a lot of that will be collaboration and intense collaboration with all departments, but we can outline that for you. It's a quite intense process for us.
Yeah. Thank you. Your budget for this year, including the shared service allocations that Member Holmes was talking about, could you tell me how they align with the top needs identified in your community health needs assessment?
Yes, so our last community health needs assessment was 22. I believe there's another one starting up for the next 3-year cycle. We know that in the CHNA for Chittenden County, the top areas of issues were access and integration of care. Over the last 3 years, we've embedded mental health in every single primary care office. I think it's actually across the network now, but I know everyone at the medical center. The ability for patients to be seen for mental health use at the same time they're seeing their primary care providers has been a game changer for the patients and families, but also for the providers. And when I round in those offices, the increased satisfaction from the staff of getting that treatment immediately for patients is amazing. And the access is quite good to get in to see the mental health providers. Cultural humility was another major issue for our last CHNA, and we've trained more than 1,100 providers at the medical center on cultural humility, and we will roll that out to all staff in 26. Food insecurity is another one. We've added food pantries to some of our pediatric clinics and ID. We've made investments in sessions for housing and mental health direct service providers across Chittenden County through our annual $1 million grant process, where we provide services that are totally based off the CHNA the last cycle. And we can submit this sheet to you of all the investments we made each year, 23, 24, and 25, that align exactly with our CHNA.
Thank you. Would you be able to follow up after with any written examples of where the shared service expenses were reduced or delayed or renegotiated because of an impact on local priorities, where you adjusted your shared service expenses so that you could better meet those community needs?
I'm sorry, I didn't exactly answer what you asked. I will say I see that as a little differently. I see the CHNAs as local to each HSA and the hospitals. And so the medical centers needs from our CHNA might be a little different than Porter's and CVMC's. And we have a very clear mechanism here and dollars aligned to do that work. So I'm not aware that we've changed our shared services budgets around that work, but I can tell you that the shared services budgets do line up with trying to make sure we have high quality care, safe care, issues like that. But I don't think we have, I haven't seen anything where we adjusted the shared services for a local CHNA.
I appreciate that. That candor, thank you. I'd like to shift gears a little bit with looking at the projected revenue losses from the budget price from your price decrease in Act 55. What adjustments have you made or do you anticipate making to manage any shortfall that results from those price reductions in Act 55?
So I will just start by saying we have tried to include everything within our budget to manage around that. And then I would also like, because this isn't just affecting UVMC, I'd also like to offer up either Rick Vincent or Dr. Epen to chime on their thoughts around that, because it is global, even beyond our health network.
Yeah, I think you actually had a slide in your presentation, Judy, that hit on three of the key items there. So the administrative shared service expense reductions are a big piece of what's helping to offset that commercial rate reduction. The clinical service or the clinical costs reductions, which is both, as Dr. Leffler pointed out, it's both a decrease in expenses internally, but it's also many of those items that are on that list is actually going to be a decrease in terms of commercial costs as well. So as we decrease length of stay, decrease utilization of imaging, lab tests, that sort of thing, that's going to save the insurance companies money as well. And then the last piece is the traveler reduction. So those three items are a big piece of what we had to do to essentially be able to offset those revenue reductions and still maintain the much needed margin that we need for the UVM Medical Center, given where we're at financially and all the investments that we've fallen behind over the last few years that we need to make.
Thank you. In the last 5 years, have you made any changes to how positions are classified between administrative and clinical categories and Medicare cost reports?
I'm not aware of any sweeping changes that have been made. Anytime we're preparing any of our official reports, we would certainly look to validate the information, but there's been no initiatives around making changes such as that. We do, go ahead, I apologize.
Do the methods that you're using, the allocation of system level administrative staff in your filings, did that align fully with Medicare cost report standards?
Yes, it did.
There appears to be about $98 million in UVM Health Network home office labor expenses that are subtracted from UVMMC's administrative labor costs. You see that on worksheet S3 of the Medicare cost report. Help us understand why that occurred.
So I think that we want the cost report experts to respond directly to the question, member Walsh, but that is what I believe is taking costs out of the UVM Medical Center that actually belong as part of the administrative shared service allocation. So the UVM Medical Center houses more administrative expense when you look at the cost report at first pass than what actually shows up in the final version of the cost, because it has some of the shared services that need to be allocated to all the other partners in the network. So my assumption is that's what that 98 million is.
When those dollars are, the network dollars are taken out of UVMMC's administrative labor, where are they then placed?
They're then placed, again, I'm kind of over my skis a little bit here, Member Walsh, so probably best to respond to your questions with our cost report experts. My assumption is it goes in the home office cost section of the cost report, but probably best to get that specifically answered.
Okay. And with that information, I'd like to understand how that change in labor cost classification flows through the rest of the Medicare cost report, including the wage index.
Got it. We will follow up.
Thank you. That's all I've got. Back to you, Chair Foster.
Thank you. Who is a Medicare cost report expert?
So we have two people internally, Amy Vaughn and Lynn Winters.
Are they here today? Can they testify?
I don't believe they're here today.
Okay. If you can reach out and see if they can be available in the afternoon for the health network portion, maybe we can address some of it. Written responses back are helpful and there's an appropriate place, but also the back and forth is helpful for us to explore the topic and issue. So thank you for doing that. I'll turn to member Ticho.
Great, thank you. I wanted to start with a little bit of follow-up on your discussion of using system tools to be more efficient in the future. And specifically, I'd like to ask you about how UVMMC is using artificial intelligence and in what processes.
I could cover a little bit of clinical. I'm sure Dr. Harrington can add some detail to that. I know in the ED right now, we're using a fracture tool that helps the ED providers and radiologists identify fractures in real time. We're using a tool right now in many of our offices to help with dictation. It's an AI tool. I know that we're adding an AI tool for mammogram reading that helps identify negatives. I know it's helping with our scheduling tools. Dr. Harrington, if you're willing, what am I missing?
Steve, you hit all the ones that are currently in practice. To be clear, there's quite a number of things that are out there and available that we're looking at as we move into FY26, particularly in the radiology space, to speed up reads and potentially improve diagnostic improvements.
Great, thank you. It sounds like you're using it in clinical and processes and also in revenue cycle management. Is the dictation tool the one that you talked about last year, which is a bridge, I think it's called?
That's correct.
Okay. So, generally AI is an expensive investment, but you expect a return. What kinds of dollar or efficiency returns do you expect to see from these investments?
I know that for each tool that we've purchased so far, we've done a business case model and been able to show the return on investment. I know what happens as part of our business case presentations. I can't give you an exact dollar for each one, but they all do pencil out to be positive over time. Sometimes not immediately, but over time.
Great. I think I'd be most interested in knowing what the business case model is for the ones that you're using in revenue cycle management.
Okay, we will get you some information on that.
That'd be
you.
great.
Yeah.
And then one other follow-up, are you using AI with prior authorization?
I do not know. Judy, do you know?
We are looking at that with opportunity. We have some internal things that we do to try to automate, but in terms of artificial intelligence, that is still on our radar. Rick, I know you've been closer to that because it is a shared service, if you would like to respond as well.
Yeah, the AI tools that we're using currently, member Teach Out, is primarily in the coding space.
Coding for what specifically?
So coding for radiology and pathology right now, and looking to expand into other areas. And the business case for that is pretty straightforward. The cost to code services is definitely less expensive with those tools. So we'll get you that.
Great, thank you. And then one other prior authorization follow-up. Since the change in Vermont statute that began on January 1st, that eliminated prior authorization for primary care ordering, has the medical center seen a reduction in costs in that area?
would you like me to chime in? So,
Yes, because I'm
I was
thinking of it in
looking-
terms of recent events and employees impacted. So thank you, Kelly.
I remember Teach Out. We don't have final numbers. We actually had a team meeting and last week, excuse me, and meeting with DFR has occurred as well. We have anecdotal reduction in some barriers, but we still have had barriers to implementation in terms of how PCPs are recorded in the system. And then the FTAs have not been reduced if we have had reduced workload there because they're focusing on the rest of the work that has been behind. So we've gained efficiencies and we're working to see how we can capture that information in partnership with BOS and VMS.
Great, thank you. Any more follow-ups when you get harder data would be great.
We'll certainly do that.
Thank you. So I want to jump to the charge master question, so maybe you should stay on and follow up a little bit on what Member Walsh asked about. So you are proposing to increase the charge master by 3% despite doing a commercial rate reduction. And I'd like you to talk a little bit about the reasons why you feel that that's required.
There's a couple of factors. The largest primarily is lesser of terms that we have to track and make sure really our charges align with our payers' revenue. That's Medicare and most of our commercials have it. It's also something as we're tracking to make sure our revenue that we actually get paid from the payers is aligned with charges. We've had years where they've gotten out of alignment where we haven't made charge master increases and we've had payments increase through commercial rates, and it creates issues not only with lesser of, but some other reimbursement terms that discount off charge various terms. So it's a matter of keeping our revenue in alignment with how things are charged.
So can I follow up on the lesser of rule? My understanding is that only applies to the professional fees and not to inpatient or outpatient. Is that true?
That is not true. Some outpatient also have that.
Some outpatient, but not inpatient.
Inpatient, and we can perhaps follow up as well. Inpatient can also impact DRG performance on outliers. So that's where charges do matter. And that's just across payers as well.
Okay. And then do you believe that many of your charge master rates are below Medicare payment rates?
Just tracking to the question there. We did respond
in
one of
didn't make sense.
did respond in one of the questions. We in average, we look at % of Medicare in our revenue. We could follow up with a more detailed, it would take more detailed line by line on the code. So I don't have that line. We did respond in general. We do look at our revenue as % of Medicare in aggregate.
Okay. And then the second reason you cited was the cost to charge ratio. Can you talk about that a little bit?
Not cost to charge, % of charge, reimbursement. Just want to make sure using the terms. Some services, and I would say I'm answering this somewhat as part of the health network because some of our hospitals have more % of charge because they don't have enough volume to do a set fee. So again, this depends on the payer, the contract. New codes, for example. So it is a variety. And if you don't adjust your charge master when you're adjusting revenue, sometimes you can have where you're paying above or below charges. So we have to keep those in alignment.
Okay. And I don't think I'm confused, but there is also a cap on this % of charge, the amount, there's a limit.
Could you I'm not understanding your question.
Yeah, sure. So I think there's a limit on what Medicare reimburses when you get your % of charge up high.
Oh, Medicare. I wasn't sure on which payer.
Yeah, sorry,
I would actually
Medicare.
have to bring in Amy to support. She's a partner on kind of the Medicare reimbursement component. So I'd like to have support there.
Great. Sure. When we follow up with her, we can include this. And I guess maybe I'm confusing the ratio with the %, but I found a file showing that Vermont as a state had the third highest of any state in the country of these Medicare cost to charge percentages?
That is a different than what I was speaking of reimbursement as a percent of charge, or sometimes you hear it as discount of charge, is not the cost to charge ratio. That would come from a Medicare cost report.
Okay. And then you did mention the discount off charge. There was a public comment from Blue Cross dated August 4th saying that increased charges directly increase the cost of services paid as a discount off charge. Can you talk about how this will impact commercial payers and what UVM MC will do to adjust?
So some of this might have to go into executive session. I'll answer at a high level if I'm not getting to that because of our contract terms. In general, when we apply our commercial rate decrease, which we have a minus 7.9, that takes into account, and I believe your staff had onto it, the percent of a hospital's revenue that's from a charge master increase. As you know, our contracts go into effect on 1/1 for a majority of our commercial payers. So every year we take into account the 10/1 increase and balance that with exactly what you have. So if a charge increase, it comes on 10/1, and yet we're reducing our commercial rates on something that is a discount or percent of charge, we will adjust then the percent of that charge the payer pays. So that'll get adjusted to come out to the approved commercial rate.
Okay, I'll ask the more detailed question in executive session. So I did want to go to the UVM balance sheet, UVM MC balance sheet. And I believe it showed a 6.77% increase in cash and investments from 25. Is that correct? And then how would you characterize this rate of growth?
Do you have that document available? And happy to provide a response back once I'm able to take a look at that. If that's all right. Member Teach Out, I can provide that.
Sure, I'll do that.
Thank you, I appreciate it.
And then there was an other revenue sheet. I think you'll know which one I'm speaking of. It showed FY25 budget, FY25 projected, FY26 budget. And I wanted you to explain the premium revenue and payer incentives line.
Kelly, did you want to respond to that?
I can probably give a little bit of explanation there, member Teach Out. So I assume you're seeing it decline from budget to budget. Is that your question?
I think so. I should have pulled it up again, and I don't know if I did. Yes.
Yeah, the biggest piece there is there. So with OneCare ending on December 31st of this year, that line does have a fair amount of population health management payments, care coordination payments, those types of things that with OneCare ending, we've got 3 months of those payments, so October through December, rather than the full 12 months that we've had in years past.
Okay. And then also on that same sheet, there's some significant gains in 340B and and specialty pharmacy. And then it's the same sheet that has the cafeteria and parking revenue. Are these included or excluded from NPR?
It's not net patient service revenue, but it is included in our total revenue. But specialty pharmacy, retail pharmacy are not part of net patient revenue. That's not part of our care delivery.
Can you explain a little bit more why that's not part of care delivery? These are the medications that are being administered, I believe, in that outpatient setting, and also drugs that patients are picking up from your retail pharmacy.
In terms of why they're excluded or not an included part?
Yeah, just the rationale behind that.
They're not part of our inpatient services that we provide. They're not part of our outpatient services. They really are a retail service that is not part of what we're doing with commercial rate. They do not impact our commercial rate request in a negative way. And I don't know if anybody else wants to chime in on, philosophically why that would not be, but there's also expenses down there that are directly related to those service lines that, again, they are not having a negative impact on our commercial rate. If anything, it would be the other way. Rick, I saw you came off mute if you want to add to that.
Yeah, they're definitely part of providing the overall services to our patients, because even the retail pharmacy operation and the other components of our pharmacy help to support the patient. So we have embedded pharmacists within the clinics to help keep patients current with their medication lists and to help ensure adherence to those medication lists. In terms of where it shows up so I would consider it as part of taking care of our patients. In terms of where it falls on the profit and loss statement, it's essentially kind of a GAAP accounting, if you will, that it's not directly related to the transaction of providing patient services. So it ends up still a revenue item, but not in the net patient service revenue section of the profit and loss statement.
Okay, thank you, Rick, I apologize, member Teachout. Thank you, Rick, for clarifying that in terms of my usage of not part of patient revenue, thinking of an accounting perspective of it, not of care of patients. So thank you, Rick, for that, and thank you for letting me clarify.
Yep. So just one further follow it there. So how are these revenues then accounted for when you're determining the commercial rate request of 2.3%?
All revenues and expenses are looked at when we are looking at basically what is it that is needed to support our patient care population. So there isn't a separate fund that sits out there that's excluded from our review for affordability and accountability. So those are very important funds that help with the delivery of care. They're just not subject to certain components in the accounting gap or within the state in terms of being subject to our provider tax. But we certainly consider them, and they're extremely valuable in our overall means of delivering care.
Great. And so you would also include the cafeteria and parking revenues in that consideration?
Yes.
Okay.
All revenue is important, and all revenue is utilized in support of our patient care.
Okay. Then to get to one more really specific one, graduate medical education. I've noticed over time, and I'm not exactly sure how it works, but that you've increased the amount that you're receiving between FY23 and FY26. It seems like a few years ago, there were some pretty significant increases. So in FY23, I think it was 21 million. And then it looks like another 7 million to 24. And then I'm wondering why you have it flat for the difference between 25 and 26 at 65.6 million. I thought that there was going to be another $7 million increase roughly.
The numbers that we have, they're based upon our communications in terms of what it is that we're receiving. There's actually, and that we can also go through that this afternoon. Amy Vaughn will be available also with that. We do validate and verify what the calculation will be in conjunction on that to ensure that we have that accurate. So there's not always a guaranteed increase, and additionally to that, if we have more residents coming in, there's not any type of automatic bump for that.
Okay.
So you see the revenue up there, the expense is in our expense section. So there are a few items that it's not always as clear in terms of what the net impact of those are. And if that's something that you would like, we can certainly look into that and the timing. We do have that broken out over the years. The other items that are up in our revenue are grants. And those grants are completely used, the grant revenue is completely used to offset the grant expenses that are in our expense section.
Great, thank you. I wanted to ask you very briefly about your commercial insurance denial rate assumptions. You mentioned briefly in passing that Medicare Advantage is part of your denial rate analysis. What else goes into your assumptions there behind that number?
We look at historical, we look at most recent trends, and we also look at what's avoidable. So we're always looking at what can we do to reduce the denials, and the trends are very important. We look at them at minimum on a monthly basis. I review them at our monthly close. We review the drivers behind them, and we look at, is it something that is avoidable, or is it something that is part of the delivery of care, but we will not get paid for it, but is not a change in practice that we would have. We go all the way down to orthopedic surgery. If Medicare pays for 13 screws and we consistently charge for 24, if it's clinically necessary, we're going to continue to use 24. So we go very detailed into line item denials and any type of procedure denial. We've also implemented an escalation process if we're unable to get a prior auth for an urgent care delivery need. Then there's an escalation process that goes to our chief medical officer, is also reviewed by me to understand what the financial impact, always keeping the patient need in the forefront to ensure that we're analyzing anything that could create a denial based upon what patient need is, and ensuring that we have those medically cleared.
Were any of the sort of reduction in barriers that Kelly discussed earlier in the prior authorization process, are those improving that denial rate?
So I know Kelly mentioned that, we're still looking at data, but we are seeing an improvement, but recognizing that payer requirements do change significantly more than annually. So there is a continual catch up. Once we see, any type of changes that they've had, we are having to adjust. But anywhere that we are aware of the opportunity to remove, reduce, or work with payers for improvement there, we're certainly doing that.
Great, thank you. And my last questions are around your health assistance program. We did receive a letter from a member of the public who asked why UVMMC is changing the requirements to qualify for the program. And I was curious how much these changes are saving the hospital.
In terms of looking at the numbers, did not see savings in there. We are looking at ensuring that there's not significant growth that can't be managed. And I do know that we have a document that outlines what our program is and what our spend has been for the past couple of years. And if you've not had access to that, we'll make sure that you get that as well.
Okay, so it will slow the rate of growth, but not produce a savings. Is that what you're telling me? The changes that are being made.
Go ahead, Rick.
Yeah, just looking at the chart that we provided member teach out. So it looks like about $6.7 million worth of benefit in fiscal year 24. And then fiscal year 25 year to date, we were already at 6.3 million. I don't know exactly how many months that makes up, but we can get you that projected number out, but it looks like it's not, at least for FY25, it's not decreasing from what it was in FY24.
I believe that the changes that the person was discussing were effective on maybe October 1st, your next fiscal year. So would it show up in the FY26 projected?
So we don't have an FY26 projection on this chart. So, and I don't know if we've done one, but we can ask the team here.
Okay. Thank you for that. I was just curious because there's a lot of discussion in your narrative about care coordination, especially with independent primary care physicians in your region, FQHCs, the DAs, and this one policy change, there could be other things going on, seems to contradict that sort of attempt to more closely align amongst all of the providers.
I do want to, I'm not an expert in this area, but I do want to say that based upon the knowledge that I have for another HAP program being opened, I do think that that will assist in the coordination of care.
Okay, great. Chair Foster, that's the end of my questions.
Thank you. One brief follow-up on that. Was there any discussion of financial savings from the change in the program?
I did not have any.
Okay. I see Mr. Rick and Ms. Vincent shaking his head as well. All right, I'll turn to Dr. Merman.
Thanks. I don't know if anyone from the finance team could put up the bridges document. It would be super helpful.
Be 1 second.
It's really just to follow up, I think, sort of a little bit on what Member T-Chat was talking about, but maybe a slightly different approach. So I think it'd be helpful just to walk through some stuff on this document. Actually, no. I was looking for the bridges one off the third tab on the rate decomp sheet. Is that possible?
That, Dr. Merman, there may be some confidentiality stuff on that worksheet. I would prefer not to show it until we.
Oh, okay. I thought we checked on that. All right. Well,
I stand corrected. Nope, it shouldn't be confidential. Let me pull it up.
All right.
Give me 1 minute.
The first two tabs are confidential. While we're waiting for that to come up, I just have a question. Do you have any prepaid expenses in the FY26 budget that are to be paid for years outside of FY26, FY27 or beyond? Is there any prepaid expenses in the budget?
I am not aware of prepaid expenses in detail. It would not be unusual for prepaid expenses to exist within a budget that are amortized throughout the period in time in which they cover. But we can certainly look and provide that information back.
So an amortized expense would be the proportion that would be due for that year's proportional expense, but I'm curious about for expenses that would be not proportionally attributed to that year. For instance, would you prepay the total bill on something that would last for 3 years or 4 years?
So if you prepaid for something in FY25, you would then amortize whatever appropriate amount would be due for 26 and beyond. If you were to, the opposite of that would be if there was something that was due that had not been paid for in a prior year that might end up impacting a later period. And I'm not aware of anything that's outstanding that would require or materially impact our FY26 payments.
Great, thanks. All right, so Matt, you can put that back up. I was just doing something while we're doing it. So this is the bridges document, which I'm just going to try to pull you to certain figures here. So in column A, row 12 is the total gross revenue budget in 25. And then what was done here is deductions and denials are row 13, sort of reference cell number 2. And then And then reference cell number 4 is bad debt and charity care by payer. So you broke it out by payer. Okay, so we look at Medicare, and then below that, the green row, reference cell 5, is the adjusted NPR. So I'm calling that, for sake of for my conversation here, I think it's, you call that NPR adjusted for deductions, denials, and bad debt, or I called it NPR deductions plus. But so if you look at the ratio of Medicare in that green line to the Medicare commercial, it's 592 million to 2.18 million for Medicare. And if you go down and look at the 26 budget, which is down here at the bottom, you can see that's 629 to 2.4. And so that ratio actually goes down a little bit. You're expecting lower, and it looks like you're expecting basically more denials from Medicare. And then a very similar thing for Medicaid. It looks like you're expecting more denials from Medicaid. And then major commercial, it's actually really different. So it's like the ratio of 909 basically in FY25 to 1.16 for major commercial compared to 920 to 1.13. That drops it from like 78% collections to 70% collections. So can you explain to me why you're expecting to get lower collection rates on your major commercial in 26 compared to 25?
I can maybe help to answer that, Judy. Matt, do you mind just scrolling back up to the top of the sheet there? So I think one of the items, Member Merman, is if you look at the reference cells 6, actually I think it is just 6. You look at that denial line there. So when you were looking at reference cell 5, all of those denials essentially were, or the vast majority of those denials were in that other category, so that column H. And so what the accounting change that Judy mentioned at the beginning of her presentation was taking those denials and allocating them out to all the different payers. So if you look at that column H for the denials, you can see that there's $35 million worth of denials that's coming out of that category, and it's getting allocated to all the different payers. In total,